Okay, right. So, Saksham, the class will be fully uploaded by evening 6:37. Okay, and yes, all cases you have to start prophylaxis for Group B streptococcal infection, Saksham. Okay. So you have to start antibiotics because you have to start prophylaxis for Group B strep in all women who come to you with preterm labor. All right, Saksham? Yes. So Yash, beta, there is no active phase in the second stage of labor. So active phase is only a part of first stage. So first stage को आप दो में divide करते हो, latent और active. Second stage में कोई active phase नहीं है. So what we say is we start plotting from active phase and you will go on to the second stage. ठीक है? So there is no active stage of second stage. All right? Chalo. So, so as I said, we will first be doing, before we go on to the postpartum period of the woman, we would first be doing a little part of labor that is left from the yesterday's class. And those are actually malpresentations. We have done breech in occipito-posterior. So today I would first talk a few things that you should know about transverse lie, right? Now, as I mentioned previously that when you talk about transverse lie or any malpresentations, the risk factors are same, okay, for all malpresentations. So जो भी हमने कल risk factors पढ़े थे, वो सब will be risk factors for transverse lie as well. But when we ask you what is the most common cause or risk factor for transverse lie, then you have to know that it is going to be prematurity. Right? So the more preterm the baby, the more likely is it that it's going to be in transverse lie. ठीक है? लेकिन इसी बात को when we talk, in a clinical manner, then the same thing can be asked in a different format. Devesh, beta, please just exit the window and come back. एक बारी window से exit हो जाओ and then join the window back. Okay? Devesh? Yes. So, मैं बोल रही थी, यही बात को पूछने का एक और तरीका भी है. They will ask you, what is the most common cause of transverse lie at term? Okay, so what is the most common cause of transverse lie at term? So you know what they are trying to ask you here? They are asking you term, which means they have already ruled out prematurity. So अगर आप term पे transverse lie देख रहे हो, then as a clinician, why should you know the cause? Because this is a one-liner, but this is clinically very, very important because this is what you have to rule out. So if a lady comes to you at term with transverse lie, you must always look for placenta previa, right? So before you actually go ahead and do a PD exam on your patient, right, to see whether she's in labor or not, please rule out placenta previa. It's very, very important, right? Also, when it comes to transverse lie, yes, it is a malpresentation and it is high risk. But you have to know what are the major adverse outcomes when you talk about transverse lie. Why are we so worried about when we talk about a baby in transverse lie? So one of the most important things, as you know, is going to be prematurity. If she goes into labor, right, the baby is going to be premature and the highest risk of neonatal or the most common cause of neonatal mortality is prematurity. So one of the adverse outcomes is prematurity. Okay. The other important adverse outcome is umbilical cord prolapse. Now ये बात please ध्यान से समझेंगे. कल हमने breech पढ़ा था and in breech also there is a higher risk of cord prolapse. But when it comes to transverse lie, this actually has the highest risk of cord prolapse even more than breech presentations. So the risk of cord prolapse is highest in transverse lie. You know it is an obstetric emergency, right? So this is again very, very important. Then because there is no mechanism of labor in transverse lie, the chances of fetal trauma are also very high. The baby will get stuck, right? So there is absolutely no mechanism of labor for transverse lie. So chances of fetal trauma are very high. And if you don't take or do the right interventions at right time, this can also lead to uterine rupture. So these are the most important adverse outcomes when you talk about transverse lie. Yes, I'm going to repeat this part. Okay, so I said, why are we worried about transverse lie? Because it is associated with major adverse outcomes, right? And the major adverse outcomes associated with transverse lie are which all? So one is prematurity, okay? Then it has the highest risk of cord prolapse, okay? So what I said was that there is high risk of cord prolapse in breech. We did it yesterday, but the risk of cord prolapse is highest in transverse lie, right? So the risk of cord prolapse is highest in transverse lie. Then what I said is that there is no mechanism of labor in transverse lie, okay? So the baby can, if she's allowed to go into labor, the baby is going to get stuck. And if the baby gets stuck, there is going to be fetal trauma. So the risks of fetal trauma are also higher. And if you don't take the right decision of operating on the woman, then there is a high risk of uterine rupture as well. Okay. Now, I was saying that if you're sitting in the gynae OPD and you're doing the antenatal checkups and you see a woman who is 36 weeks pregnant, has transverse lie, what are you going to do? Yes. So what do you do here? So at 36, we should ask for a repeat ultrasound, right? अब आप लोग मुझे बताओगे, we've done the concept yesterday. So you are going to tell me, why should you do a repeat ultrasound in this patient at 36 weeks? Why would you want to do an ultrasound at 36 weeks? So we would want to do an ultrasound at 36 weeks. Number one, especially as I said, to rule out placenta previa, right? So we have to do an ultrasound to rule out placenta previa. What is the second reason to do the ultrasound? To look for, okay, prerequisites. So to look for prerequisites for what? External cephalic version, right? कल भी मैंने आपको बताया था that external cephalic version is a procedure, okay? It is a procedure that is going to convert non-cephalic presentations into cephalic presentations. Okay? So, before you actually take up the patient for external cephalic version, you have to ensure that she meets the requirements, right? That it's a singleton pregnancy, the liquor is adequate, and all those things that we talked about yesterday. So you should do an ultrasound to rule out placenta previa and to look for prerequisites for external cephalic version. Okay? Now, once we have ensured that she can undergo ECV, this is what you should try. So again, once you have ensured that prerequisites are met, we will take her up for an external cephalic version. I told you most commonly we do an ECV at 37 weeks. So we will do an external cephalic version at 37 weeks. Is this clear? Now, what is going to happen after this depends upon the outcome of this. So let's presume my external cephalic version is successful, right? So my bachche ko, I could convert it into a cephalic presentation. So I will leave it and then I will let it go into spontaneous labor, right? If my external cephalic version is unsuccessful, right? Then what are we going to do? Now, यहाँ पे आपको मेरी बात ध्यान से समझना है. So if the version is unsuccessful at 37 weeks, can you try it again? Yes. Okay. So हम 2 बार external cephalic version actually try कर सकते हैं. So I can actually try it again at around 38 to 39 weeks, right? So एक हफ्ते के बाद I will try the version again, not immediately. So after 1 week, I will call her back and I will tell her that we will try and rotate the baby again. Okay. So At 38 to 39 weeks, now if the version again is unsuccessful, we will take her up for a elective cesarean section. Right? So then we will take her up for a elective cesarean section at 39 weeks. संस्कृति IPV नहीं बेटा, IPV का सिर्फ एक ही इंडिकेशन है संस्कृति. It is the second twin of a twin pregnancy in transverse lie. So not a singleton, pregnancy. In singleton pregnancy, beta, you will do external version. You don't have to do an internal podalic version. Okay? So you repeat the ECV again at 38 to 39 weeks. If it is successful, well and good. If it is not successful, you will take her up or post her for an elective cesarean at 39 weeks. Is the algorithm clear? Yes, is the algorithm clear? So the algorithm was also important to answer the recent AIIMS MCQ. And as I said, when I say recent, I mean last 1 to 2 years. Okay? So this is an important algorithm. You should know what we are going to do for the patient. Right? So you first try ECV at 37. Right? If it is unsuccessful, you can send her home. You can call her back at 38 to 39. And now if it is unsuccessful, you can take her up for a cesarean at 39 weeks. Now this is when the woman comes to us in the antenatal OPD, right? She is coming to us in the antenatal OPD at 36 weeks and she is transverse lie. ऐसा भी तो हो सकता है that this woman comes to us in labor. हो सकता है कि नहीं? Yes? So if she comes as transverse lie at term and she is in labor, then what are we going to do? Okay, so वो था जब मैं उसे OPD में देख रही हूं और अब मैं आंसर कर रही हूं अगर मैं उसको लेबर में देख रही हूं. So this will again depend in which phase of labor my patient is. If she is in the latent phase of labor, right, then I can do a external cephalic version still. क्योंकि आपको पता है ECV is done under tocolysis, है ना? So you can give drugs to stop the uterine contractions क्योंकि वो mild ही होंगी अभी, right? And you can still try an external cephalic version, right? If the ECV fails, then take her up for a cesarean section, right? So if the external cephalic version will fail, then I will take her up for a cesarean section. But if my patient is in active phase of labor, okay, so if my patient is in active phase of labor, then what do? Then you have to take her up for an emergency cesarean section. You will not do ECV if the woman is in active labor, right? यहाँ पे भी please understand, मैंने बोला है do an ECV if she is in latent labor, मगर हमेशा when you are going to do an ECV, you have to look for prerequisites या requirements. The requirements for ECV have to be met. If they are not met, then even in latent phase, you will have to take her up for a cesarean section. For example, let me ask you this question. So let's do a patient here. So let's say the next patient, we are sitting in the gynae casualty, comes to us at 37 weeks with transverse lie, right? With complaints of leaking PV for past 1 hour, right? On examination, cervix is 2 centimeter dilated and 50% effaced, right? What is the management of this patient? Let me see how many of you can answer it correctly. So the patient is coming, you are sitting in the gynae casualty. She is 37 weeks. The baby is in transverse lie. She is complaining of leaking PV for past 1 hour. Cervix is 2 centimeters dilated, 50% effaced. What are you going to do? Tell me, who is going to tell me the answer? What is the answer for this question? क्या करना है बच्चा? So whoever answers correctly will get a chocolate. And let's see, आज की class के end में we'll do a chocolate tally. Yes, who has won the maximum chocolates in the obstetric class? Very good. So Ayushi is the first one to answer. Excellent. Ayushi is right. The answer is cesarean section. Ayushi, I want you to give me a correct explanation as well. Your answer is right. But why is it the answer cesarean section? Why not external cephalic version? She is still in the latent phase of labor. Yes, abhi 2 centimeters hi hai. She's in the latent phase of labor. Why not external cephalic version? So to answer this question, आपको अगर आपकी वन लाइनर्स या आपका कंटेंट अच्छे से पता होगा तभी आंसर कर पाओगे. So you have to know here that absent membranes or leaking PD is a contraindication for what? External cephalic version. So to answer all these clinical questions, you have to know the basics of ECV. Only if you know them correctly, will you be able to answer these MCQs, right? So the correct reason is because the membranes are ruptured, you cannot do an external cephalic version even if she is in the latent phase of labor. Is this clear to everyone? Okay. Now, let us look at next patient who is going to come to our OPD, right? So, let us say your patient in the gynae casualty is a case of 38 weeks pregnancy and she's come to you with transverse lie, right, with hand prolapse. So hand prolapse is very different from compound presentation. Do you remember? ये मैंने कल labor की class में भी सिखाया था. Compound is when two things are presenting together. I will show you what hand prolapse is. Hand prolapse is जब एक हाथ बाहर निकल के आ जाता है, right? So she has come to you with hand prolapse and on examination, the fetal heart rate is absent. Okay. So on examination, the fetal heart rate is absent and maybe with this, I am going to show you a image. So in the exam, they may give you the image as well. So they will say 38 weeks, transverse lie with hand prolapse and the following image. Yes. What are you going to do for her? So this is the image. Can you just look at the image and tell me what is happening here? ये भी चीज मैंने कल आपको पढ़ाई है. So now I want you to recall it actively in the class and tell me, yes, what is the finding in this image? Anybody? What is the finding in this image? So if you look at this image, this is a hand prolapse. So this is what is hand prolapse. This is not shoulder presentation. This is not shoulder dystocia. Okay? बहुत सारे बच्चे shoulder dystocia को इससे confuse करते हैं. This is actually also called as neglected shoulder presentation. Right? So this is also called as neglected shoulder presentation. This is not shoulder dystocia. Okay, this is not shoulder dystocia. So shoulder dystocia happens in vertex presentations, right? So, okay, Anjali and Darshit, you people are right. The answer is cesarean to the question, but what is the finding here? Let's find out the correct reason. So look at the upper segment. If you see, the upper segment of the uterus is tonically contracted. Right? Look at the lower segment of the uterus. Right? So this is the lower segment of the uterus. What happens to the lower segment? The lower segment is stretched. And can you all see the ring? Can you see the ring? In fact, we have shown it to you with the arrow as well. Can you see the Bandel's ring? Yes. So this is not just neglected shoulder. So actually neglected shoulder में होता क्या है? The lady goes into what? She goes into obstructed labor. Why? Because there is no mechanism of labor. बच्चा vaginally बाहर नहीं आ सकता. There is no mechanism of labor. So eventually the woman is going to go into obstructed labor. And because poor baby has been stuck like this, there is hypoxic injury to the baby and the baby dies. Right? So a lot of times when you see neglected shoulder, या तो आपको सिवियर डिस्ट्रेस मिलेगा या आपको डेड बेबी मिलेगा. right? Is this clear? Now can you correlate two things together? Yes. So this is the image with the patient, right? So now by looking at the image, what is our diagnosis? Our diagnosis is, it is neglected shoulder presentation with obstructed labor and a dead baby. As I said, once it is obstructed labor, beta, हमारे पास कोई भी तरीका नहीं है to deliver out the baby, right? Transverse lie में anyways there is no mechanism of labor. So even with dead baby, right, the answer will remain as cesarean section, right? So even with a dead baby, the answer will remain as a cesarean section. Is this clear? Again, in modern obstetrics, we will not do what? So in modern obstetrics, we don't do destructive procedures. Right? But पुराने ज़माने में, yes, people used to do certain destructive procedures in this baby. So one destructive procedure that you can do here is, so in older times, people used to practice destructive procedures, and one of which is evisceration. The other is decapitation. Okay, so evisceration and decapitation. Let's look at the image again. So evisceration में क्या करते हैं? हम एक बड़ी सी कैंची लेके जाते हैं. You will take it up, the scissor, cut open the abdomen of the baby, right? Remove the viscera, so the baby will collapse, right? And then the baby can be delivered. Then what is decapitation? Decapitation में ऐसा एक हुक होता है, ओके, देयर इज अ हुक जिसके एंड में ऐसे नाइफ बना होता है. सो इट्स अ हुक विद नाइफ. ये आप ऊपर लेके जाते हो और जहां मैंने रख के दिखाया वहां रखते हो. सो यू कीप इट एट द जंक्शन ऑफ द हेड विद द बॉडी. सो नेक पे रखते हो एंड यू विल डू अ डीकैपिटेशन. फिर हेड को अलग निकालते हैं और बॉडी को अलग निकालते हैं, राइट? ना अनुष्का बेटा तूने लिखा क्रेनियोटमी, वही पढ़ाने के लिए मैंने ये बताया, राइट? क्या आप इस बेबी में क्रेनियोटमी कर सकते हो अनुष्का? नहीं. क्रेनियोटमी के लिए यू नीड एक्सेस टू द बेबी स्कल. In transverse lie, there is no possibility to get access to the baby's skull. Craniotomy, bacha, is done in vertex or cephalic presentations. And that's exactly, Anushka, how they will confuse you. Okay, so in the same question, the same above question, I said the lady is 38 weeks, transverse lie, hand prolapse, dead baby, right? Now the question that they will ask is, all the following can be done except, okay, what would be the options? They will say, A, is it evisceration? Okay, B, is it decapitation? C, is it craniotomy? Or D, is it cesarean section? Right? So, अब बताओ क्या आंसर होगा इसमें? All the following can be done in your patient except, what is the answer to this question? So, the answer will be craniotomy. Very good. Craniotomy, please remember, आप transverse lie में नहीं कर सकते. Okay, so craniotomy is something that you can do with cephalic presentations. Is it clear, Anushka? Yes? So don't get confused. Okay. Now, is there a possibility ki transverse lie mein? Okay, let me take this question a little further now. I will make it a little more applied. And to answer this question, I want you to recall something that I taught you yesterday. ठीक है? So इससे मुझे पता लगेगा whether you have revised your notes or not, और इससे मुझे पता लगेगा whether you can apply concepts to a clinical presentation or not. Right? So now the question for you is, we don't do destructive procedures, और इसीलिए मैंने अपने patient के लिए cesarean कर दिया. Now the patient was discharged. Okay, but she comes back. She comes back at 1 week and says that she is dribbling urine. Okay, so she comes back 1 week after her cesarean section and says that doctor, मुझे तो involuntary pass of urine हो रहा है. So she won't say like that. She will say dribbling of urine, right? Or involuntary passage of urine, right? What do you think has happened, right? And maybe, right? Maybe what is going to happen? What is going to happen? Maybe she says, doctor, you have done something during the cesarean section. You didn't know how to operate. You have done a complication and I'm going to take you to the court for it. Right? What are you going to tell her? What do you think is happened here? Very good. So I can see Disha, Darshit, Palak, Ayushi, Riya, everybody giving the correct answer. So yes, what has happened is she has developed a vesico-vaginal fistula. You remember obstructed labor I taught you? क्या होता है? I said in obstetric labor, the outflow tract or the bladder outflow tract, the urethra and the bladder part get impinged between two bony structures, the symphysis pubis in front and the head behind. So जितने टाइम में ये bladder outflow tract impinged रहता है, it suffers from avascular injury, right? And eventually this part of the bladder will undergo avascular necrosis. Yes, so there is avascular necrosis of the bladder outflow tract in obstructed labor. Okay, so as a result of which slowly this part is shed off, and that is what you have to remember. This complication is not something which happens immediately on post-operative day 1 or something not that happens intraoperatively, right? Because it is avascular necrosis, it takes approximately 7 to 10 days for this part to, slough off. So the presentation is delayed. It's not going to be an immediate post-op presentation. And that's the hint towards fistula. देखो, had it been an intraoperative bladder injury, right, तो क्या होता? Most of the times it will present intraoperatively only or immediate post-operative. But something which is presenting late after 7 days, 10 days is not likely an intraoperative injury. Yes, so this is the development of VVF. And in fact, I want you to know this because India may, or in fact developing countries may, so in developing countries, the leading cause of vesico-vaginal fistula is obstructed labor. Yes, is it clear to everyone? Okay. Now, the last thing that I want you to know in transverse lie is, क्या ऐसा कभी भी हो सकता है कि transverse lie can deliver vaginally? So एक ही चीज है which I want you to know जो कि theoretically किताबों में लिखी है, and it's called as corpora conduplicata. Okay, this is what? This is a rare spontaneous vaginal delivery in transverse lie. Okay, so this is a rare spontaneous vaginal delivery in transverse lie, right? ये कब होता है? This happens when the baby is preterm, so it has to be a small baby, and it's an old IUD. बच्चे को मरे हुए कुछ टाइम हो गया है. The reason I want you to remember the word old IUD is, it means that the baby has undergone maceration. So soften हो गया है. So baby has undergone maceration. It's a small baby, and because of small in size and because being macerated, the fetus gets doubled up. By doubled up, what do I mean? I mean it gets folded upon itself. right, and delivers. जैसे कि देखो, this is transverse lie. Now, if it's an old dead baby, what do I mean? It gets doubled up. I mean like this. So it gets folded, it gets doubled up, and then comes out vaginally. So this is the only way for vaginal delivery that has been described for transverse lie. Remember, it's a rare thing to happen, and it is called as corpora conduplicata. Yes, is it clear to everybody? Okay. Coming to the two smaller malpresentations that you should know now. So one is face and the other is brow presentation. Can you recall from yesterday's class and tell me what is common to them? What is common to face and brow? Anything that you can recall from yesterday's class? Anything that you recall? Something really basic I told you. So both in face and brow, the neck is in extension. है ना? So brow may we say it is in partial extension. So there is partial extension of the head, or face may there is complete extension of the head. Right? That's what is common. So what I am trying to say is the risk factors for them are also going to be common. Now, generally, yes, we say all, जो भी मैंने अभी तक आपको risk factors for malpresentations कराए थे, they will be risk factors here as well. But what is more important here is something that you should know. Anything which prevents flexion of neck, right? So anything that prevents flexion of the neck will become a risk factor for face and brow, right? For example, what I want you to know is if there are tight loops of cord around neck, right? So please remember, I have used two adjectives here. It has to be a tight loop, not a loose loop. Loose loop khul jata hai, and it's loops. So single loop is usually not a problem, but if there are more than 2 rounds of the cord around the neck, then that is a problem. So tight loops of cord around neck will prevent the head from going into flexion. So it becomes a risk factor for breech and face. Anterior neck masses. For example, a thyroid swelling or any other neck swellings like cystic hygromas, right? So they can prevent again what? Flexion of neck. So anterior neck masses, tight loops of cord around the neck, they're all going to be risk factors. Okay. Now when I talk about risk factor, you should know this. The most common cause of face presentation, okay, is anencephaly. So the most common cause of face presentation is anencephaly. Now आपको ऐसा लग रहा है कि ये वन लाइनर है, फैक्चुअल बात है, मोस्ट कॉमन है, क्यों याद करना है? बट नहीं, ये फैक्चुअल है, बट ये बहुत ज्यादा क्लिनिकली इंपॉर्टेंट है. सो व्हेन यू एंड मी आर सिटिंग इन द लेबर रूम एंड वी आर सीइंग a face presentation, the first thing should come to my mind is कहीं ऐसा तो नहीं है that she is an undiagnosed anencephaly, because the management is done accordingly, right? So you have to know that anencephaly is the most common cause of face. Yes. Anything else that you remember is common to both? So apart from risk factors, I told you yesterday again, both face and brow presentations, yes, are seen in which type of pelvis? Do you remember? Platypilloid pelvis, right? So they are seen in platypilloid pelvis. Okay, let's quickly recall a few other things that I want you to know. So when you talk about face, do you remember the engaging diameter? So this was submentobregmatic What was the value? 9.5. Okay. And when it comes to brow, it is mentovertical, right? Which measures 14 centimeters. Okay. So mentovertical, which measures 14 centimeters, right? And submentobragmatic, yes, which measures 9.5 centimeters. Okay. Now, do you remember the denominator? Do you remember the denominator? So I told you, in face the denominator is mentum, and here it is the frontal bone, right? So denominator is mentum and frontal bone. Now, please try and understand what I am saying. जैसे आप occiput की बात करते थे, we talked about positions. Do you remember occipito anterior, occipito posterior? याद है? Similarly, mentum में भी it can be a mento anterior position and it can be a mento posterior position, right? So a mento anterior or a mento posterior. Now what I want you to know is, if it is a mento anterior position, vaginal delivery is possible. Okay, so vaginal delivery is possible. But if it is mento posterior, there is no mechanism of labor. Right? So then there is no mechanism of labor. अभी ये याद रखना है, अप्लाई कैसे करना है मैं अभी बताऊंगी. ठीक है? दूसरी बात, because here in brow the engaging diameter is 14 centimeters. I'm sure you remember that this is the largest fetal head diameter. Yes, so much so that this diameter can never be delivered out of the female pelvis. So again, as far as brow is concerned, there is no mechanism of labor. Now, once you understand these basics, first I will teach you direct questions and then I will teach you how to go about indirect things when asked clinically. So direct question to yahi hai, if they ask you, your patient is a case of face presentation and she is mento posterior, what would you do now? So if they say mento posterior in labor, what is the management? So the direct answer is it has to be a cesarean, right? So if mento posterior is in labor, the answer has to be a cesarean section. If it is mento anterior, the answer is vaginal delivery. Similarly, if they give you a question which is as simple as brow in labor, right? What is the management? The answer is again CS. But as I said, these are direct, easy questions. Sometimes we could ask you more clinically applied questions as well. Now, let's go back. Labor is a long process and you all know that there is an early part of labor which we describe as latent labor and there is an active labor, right? Now we could go into more details and tell you like this. What? Your patient is mento posterior, but now I say she is in early labor. Always remember, when in exams or clinics, whenever we say early, we mean she's in the latent phase, right? So she's in early labor. Now, if we ask you, what is the management? To kya karna hai, right? So now if we ask you what is the management, you have to go back and draw a corollary. Do you remember occipito posterior? And I told you what all are possible outcomes of occipito posterior. So अगर आप मेरे को याद करके बताओ, कल मैंने आपसे पूछा था occipito posterior in labor. What was the general management? The general management was wait and watch. है ना, याद है? Because we said if you give OP time, the baby is going to completely rotate and become anterior. याद है आपको? The same rule applies here, right? So as labor will progress, the mento-posterior can actually convert into mento-anterior. So when we say early labor, you should definitely go ahead and do a wait and watch, because most of these will convert into mento-anterior. Is it clear to everyone? Okay. The second thing I want to ask you is, suppose your patient is, ऐसा लग रहा है face है on a PV exam. Can you tell me with what can you confuse a face presentation on a PV exam? So face presentation can actually be confused with breech. ये मैं यहाँ पे क्यों बता रही हूँ, बहुत सारे बच्चे मुझसे पूछेंगे ये बात, मैम हमें क्या इतनी देर तक पता ही नहीं लगा ये फेस है, why did we not do a cesarean early and so on. ठीक है, so a lot of times जब आपको बच्चा breech presentation लग रहा होता है on a PV exam, it actually later turns out to be face. और बहुत बार जो आपको face presentation लग रहा होता है, it turns out to be breech. So why are the two giving a similar feeling, and which breech actually? Frank breech. So इसका DD होता है frank breech. Why? Because in both of them, face and breech, when you do a PV, you feel an opening and two bony prominences. So in face, it is the mouth and malar prominence, whereas in breech, it is the anal opening, and I told you the ischial tuberosity, right? So, कैसे फर्क करेंगे? You simply have to move your finger along these 3 points. So, आप PV कर रहे हो और PV करते हुए you are moving your finger along these 3 points. If your finger forms a triangle, so while moving it, you feel it's making a triangle, then it says face presentation. Look at me. So it's malar prominences and mouth, right? Whereas if you feel that your finger is forming a straight line, then it is a frank breech. What else? Mouth में when you put your finger, तो कैसी feeling आएगी? Sucking, right? Sucking की. Whereas in the anal opening, it is a gripping feeling because of the sphincter. So anal opening में अगर आपका finger होगा, it's a gripping feeling, whereas if it's mouth, it's sort of sucking it up, right? Also, sometimes it is very easy, there is no confusion, because if it is anal opening that your finger is going into, you could feel the meconium staining. Right? So you will see the meconium staining on your finger, right? Whereas this meconium staining is going to be absent if it is face presentation. So these are some of the easy ways to pick up that it is face. Always do the PV very gently. नहीं तो कल जैसे हमें संस्कृति बता रही थी, I can actually, if I'm not sensitive enough and I'm very harsh, then I will injure the baby's eyes and other structures. So be very gentle when you come across these things. Right? So this is what you should know about face presentation. Talking the similar things about brow. So as I said, brow in labor, right? You are going to do a cesarean section. But again, if it is a brow presentation in early labor, then you should do a wait and watch. Why? Because as you give more time to the process of labor, क्या होगा? What will happen? Either the head will go into complete extension and become face, or it can start going into flexion. So give it more time. It will either go into flexion or extension, because we say brow presentation is a transient presentation. Right? So we say brow presentation is transient. So if you give it more time, it will convert into face or it will convert into flexion. Okay? Yes, Disha. The other way is to simply get an ultrasound done. But if your patient is in active labor, getting an ultrasound done is not quite right? So in early labor, you should, with all malpresentations, बहुत बार दिशा वही मैं आपको बता रही हूँ, a lot of times, अगर मुझे आपको फेस प्रेजेंटेशन पे क्वेश्चन देना होता है तो मैं पता कैसे देती हूँ, मैं बोलती हूँ a lady comes with 9 months amenorrhea, right, with let's say early labor and face. Right? So इसमें can you tell me what is quite unique? इसमें क्या चीज यूनिक है? यूनिक बात ये है कि अभी तक जब भी मैं आपको क्वेश्चंस देती हूँ, आई राइट 36 वीक्स, 37 वीक्स, 38 वीक्स. Here I'm writing 9 months. So which is practically we are trying to tell you that this woman has never got an ultrasound done, probably has one or no antenatal visit. She is directly coming to you in labor. What is the clinical relevance? जब ऐसा हो कि किसी ने कभी अल्ट्रासाउंड ही ना कराया हो और आप फेस प्रेजेंटेशन हो, most likely this baby will turn out to be anencephalic. So yes, get an ultrasound done. Okay, so get an ultrasound done if she is in early labor. Rule out anencephaly or gross anomalies, because we don't want to do a cesarean section for anencephaly. Right? So we don't want to do a cesarean for anencephaly. Is it clear, Disha? I hope I have made myself clear and your doubt is sorted, beta. Okay? Right. So these are things that you should know about labor as such. Now, when you are doing labor, and we've done normal labor and we've done abnormal labor, we've done prolonged labor, a part and parcel of abnormal labor and its management is instrumental delivery. Right? So we will also do instrumental delivery, and then we will do lots of questions on labor before we go on to the postpartum phase. Okay? So we would now be talking about instrumental delivery. Okay? Right. So why do we do instrumental delivery? What is an indication to do this? That is the most important thing that we have to know. Bhai, as a clinician, मुझे पता होना चाहिए करना कब है, right? So the indication to do instrumental delivery is basically when you want to cut short second stage of labor. Right? So when you want to cut short the second stage of labor, that's when we will use an instrument. Okay. Now, when we talk about cutting short the second stage of labor, why would you want to cut it short? Yes? Can you tell me why would you want to cut it short? So, the first reason is maternal exhaustion. Right? This is why I was exactly trying to tell you yesterday that we don't want a woman to bear down in the early labor, because then she gets exhausted. कल मैंने आपको पढ़ाया था for the expulsion of the fetus क्या चीज जरूरी है. One was uterine contractions, but one is uterine contractions, मगर एक और क्या चीज बहुत जरूरी थी, maternal pushing efforts. In fact, I said pushing efforts are more important for expulsion of the fetus as compared to contractions. ठीक है? So maternal exhaustion अगर हो जाएगा, then it's we would want to do a instrumental delivery to take the baby out. ठीक? The second reason is यहाँ तो है mother efforts कर नहीं पा रही. दूसरी condition होती है where we don't want her to do expulsive efforts. When maternal pushing is contraindicated. Can you tell me in which condition, because we've done this, I want you to apply it. In which condition is maternal pushing contraindicated? In certain types of heart disease, right? So certain types of heart disease, you definitely don't want her to push, because if she's going to push, there's going to be tachycardia. Tachycardia can cause cardiac decompensation and heart failure, right? So in certain types of heart disease, we really don't want the mother to push. Yes? The third reason why you would want to cut short the second stage of labor is if there is fetal distress. Now, ये चीज I really want to clarify. अभी तक आप लोगों को सिर्फ ये पता है that if there is fetal distress, you will deliver by cesarean. यही पता है ना? So अब मैं आज आपको बता रही हूँ that when there is fetal distress, you can actually do an instrumental delivery as well, right? Which is done obviously if requirements are met, but fetal distress में you can also do a instrumental delivery. Is this clear? Okay. Right. When and where will you do it? I will tell you. Right. So these are the conditions where I would want or I can apply forceps. मगर जैसे मैंने बोला इन कंडीशंस में आई वांट टू डू दी फॉरसेप्स एक्सट्रैक्शन और वैक्यूम एक्सट्रैक्शन, बट मैं कर सकती हूं कि नहीं, दिस आई हैव टू ऑलवेज फाइंड आउट. सो बिफोर यू एक्चुअली गो अहेड एंड पुट एन इंस्ट्रूमेंट, you have to look out for what? You have to look out for requirements for instrumental delivery. Only if requirements are met can you actually do a instrumental delivery, है ना? Otherwise नहीं, otherwise cesarean ही करना पड़ेगा, right? So to know the requirements of instrumental delivery, we would say you remember it as the mnemonic with forceps itself, right? Where when I say F, the cervix should be fully dilated. Now, I want to tell more detail here. Full dilatation of the cervix, which is 10 centimeters, right, is mandatory for forceps delivery. While I will say fully dilated cervix is preferred for वैक्यूम. इसका मतलब समझ में आता है? मतलब फोर्सेप्स करना है तो फुल डायलेटेशन चाहिए ही चाहिए. वैक्यूम में भी एक्चुअली में बेटर यही है कि सर्विक्स फुली डायलेटेड हो, बट हियर यू शुड नो दैट वैक्यूम कैन बी अप्लाइड. अगर जरूरत पड़े इट कैन बी अप्लाइड एट एंड बियॉन्ड 6 सेंटीमीटर डायलेटेशन. प्रेफर्ड है फुल डायलेटेशन, मगर जरूरत पड़ने पर 6 सेंटीमीटर्स एंड बियॉन्ड पे भी आई कैन अप्लाई अ वैक्यूम. इज दिस क्लियर टू एवरीवन? ओके. व्हाट इज ओ? नो ऑब्स्ट्रक्शन इन द पाथ. इसका क्या मतलब है? As I told you, labor process itself cannot get completed if there is an obstruction. For example, let's say there is a big fibroid uterus in the pelvis, or there is a big ovarian mass in the pelvis, right? So these are going to provide mechanical obstruction. There is going to be no space to apply instruments, right? R, ruptured membranes. This is very important. If you have to apply instruments, the membranes have to be ruptured. बहुत simple सी बात है. अगर ऐसा नहीं होगा तो the instrument cannot be correctly applied and it will fail. Yes. So ruptured membranes. C stands for there should be good uterine contractions. Right, so there should be good uterine contractions. E, the head should be engaged. मतलब कम से कम 0 स्टेशन जरूर होना चाहिए. Beyond a 0, -1, -2, -3. So above ischial spines, so it's a big no for instrumental delivery. So kam se kam the head should be engaged and it should be a 0 station. There is something more when I go to station and I will tell you in a moment, but this is what you need to know. Okay, the head has to be engaged. So the more, at least it has to be 0 station, preferably actually more than 0. Okay. What is P? P is favorable presentations. So in all presentations, you cannot apply instrument. And in certain presentations, you can apply only forceps. And in certain presentations, you can apply only vacuum. Yes. So now we will talk about which one to apply. But the prerequisites are very important. These prerequisites are true whether you talk about forceps or you talk about vacuum. Okay? Now, once we have seen prerequisites are met or not, what is the next thing that you will ask to yourself as a clinician? लगाने की जरूरत है, फिर मैंने देख लिया कि लगा सकते हैं, तीसरी चीज क्या देखूंगी, कौन सा लगाऊं. So should I preferably use a forceps or should I preferably use a vacuum, right? Now let's understand this. So if I ask you a very basic question, and that is, which of the two is more easier to apply? What would you say? Which of the two is more easier to apply? Then yes, please remember, vacuum is much more easy to apply and it needs no training. Forceps is more difficult to apply. And it needs training. इसीलिए आप देखोगे, आप कितना ही क्यों ना पढ़ लो कि ये लगा सकते हैं, ये लगा सकते हैं, but in most of the hospitals, when it comes to instrumental deliveries, the doctors and the residents will be using a vacuum, simply because they really don't know how to use the forceps. So vacuum is much more easy to apply, right? Please understand, the important thing is also period of gestation. Vacuum is absolutely contraindicated if the gestational age is less than 34 weeks. So vacuum is contraindicated if gestational age is more than less than 34 weeks, right? So it's very dangerous if the baby is itna preterm, right? So then we will be preferably using forceps if at all there is a need. Then remember कि forceps में maternal effort is not required. Right? So maternal effort is not required. इसीलिए जब मैंने आपको हार्ट डिजीज मैंने पढ़ाया था, मैंने बोला था हार्ट डिजीज में both can be used. Because we have to cut short the second stage, we can use a forceps, we can use a vacuum, but then I also said, generally we will prefer forceps over vacuum because you don't want the mother to bear down, okay? Then, when it comes to forceps, this is what you can apply to face as well as to breech presentations. Whereas, can you apply a vacuum on face and breech? No, right? Vacuum lagane ke liye, we need a hard surface like the skull to create the negative pressure. Face and breech are soft tissues. You can't apply a vacuum on somebody's nose and pull it off, okay? So it's contraindicated. Now here, I'll go into a little more detail. Let me see how many of you can apply your knowledge and answer a clinical question. Suppose your patient has face presentation. In which kind of face presentation can you think of applying forceps? Batao. Is it in mento anterior or is it in mento posterior? That's what I want to ask. So, face maybe it can be applied only on mento anterior positions, never on mento-posterior, because what? There is no mechanism of labor for mento-posterior. Yes? Breech, maybe I had taught you what? Breech, may I had taught you, you apply forceps for after coming head. Right? So you apply forceps on the after coming head. Do you remember the name of the forceps? I told you it's a special forceps. We call it as a Piper forceps. Okay, we call it as a Piper forceps. So if it's these malpresentations, you can apply forceps, but you cannot apply vacuum. Okay? Now, also when it comes to forceps and vacuum, which of the two will you prefer if there is fetal distress? Now again, when it is fetal distress and the requirements are met, I can actually use both forceps and vacuum. But forceps will be preferred over vacuum. I will tell you the reason why. Vacuum लगाने में जब हमें pressure raise करना होता है, it is gradual elevation of pressure. तो आप बहुत जल्दी जल्दी नहीं लगा सकते, right? So that is why we say forceps can be quickly applied, but this comes with a rider. The rider is provided the clinician is trained. भाई अगर वो trained ही नहीं है for forceps deliveries, तो फिर जल्दी और लेट का तो सवाल ही पैदा नहीं हुआ, right? If she doesn't really know how to apply forceps, even in fetal distress, she will apply vacuum. So I'm not saying that vacuum is contraindicated, but when a clinician is trained in both, then I will prefer to use forceps over vacuum, right? Is it clear? Is it clear to everybody? Okay. Then something which is very, very common and we will keep, repeatedly asking you is, out of forceps and vacuum, which causes more of maternal injuries? So I'm sure you all know that. Forceps causes more of maternal injuries, right? Injury to the perineum. Whereas vacuum will cause more of what? It will cause more of fetal injury. Yes, so it will cause more of fetal injury. But exam में वो ये वाली बात नहीं पूछते क्योंकि ये सबको आती होती है. So I don't want to ask something which I know everybody will do right. I want to be a little tricky on the questions. So they will characteristically ask, which fetal injuries are more common, yes, with forceps as compared to vacuum, right? So question ही बदल दिया, वो पूछ रहे हैं which fetal injuries are more with forceps as compared to vacuum. So this is very characteristic and that's why we ask you. So one of the most characteristic answers is brachial plexus injury as well as facial nerve palsy, right? So brachial plexus injuries, facial nerve injuries and injuries to the soft tissue of face, obvious reasons, है ना? So injuries to soft tissue of face. Also IVH, intraventricular hemorrhage, is more common with forceps as compared to vacuum. So IVH is also more common with forceps. मगर आंसर किस ऑर्डर में करना है? जिस ऑर्डर में मैंने लिखा है. So facial nerve and brachial plexus are the most important answers. फिर आता है yes injuries to face and intraventricular hemorrhage. On the same note, if I ask you, which fetal injuries are more common with vacuum? Right? So which fetal injuries are more common with vacuum? So इसमें अच्छे answers क्या हैं? One is cephalhematoma. You don't see a cephalhematoma with forceps. You will classically see it with a vacuum. Sixth nerve palsy. Right? So sixth nerve palsy. Then comes injury to the retina. Okay? So sixth nerve palsy, injury to the retina, cephalhematomas, and shoulder dystocia are more common with vacuum. Yes, so these are very very important. देखो यही चीज मैं वन लाइनर की तरह भी पूछ सकती हूँ, क्लिनिकली भी पूछ सकती हूँ. सो मैं क्या करूंगी, आपको एक क्लिनिकल एमसीक्यू दूंगी, where I will say that the next patient in your labor room had prolonged labor and then she had fetal distress and I have done her operative vaginal delivery on her. Right? So your patient had prolonged labor, then she developed fetal distress. So I have done an operative vaginal delivery on her. उसके बाद I will give you an image. I will give you an image of a newborn baby with facial nerve palsy. And I will ask you, this is the image of the baby. Which instrument do you think we have applied? Yes? So which instrument do you think we have applied? What would be the answer? It would be forceps. Yes, it would be forceps. So मैं वही आपको बोल रही हूँ, I'm trying to explain to you कि if your content and understanding is good, अगर आपका concept अच्छा है और अगर आपका content अच्छा है, content मतलब कम नहीं होना चाहिए, it has to be crisp, it has to be high yielding content. So if your content is good, yes, and your understanding is good, okay, whether we ask you an image based MCQ or we ask you a clinical vignette, things will come to you. Don't worry about it. The format of the MCQ will stop making any difference to you if you know your things well. Is it clear, everybody? Yes? Okay. Now, talking about some special things about forceps and some special things about the vacuum that you should know. Now, forceps की classification important है. Right, could be asked directly as well. So forceps में there is an outlet forceps. So to say that you are using an outlet forceps, what are the requirements? The requirements are A, the scalp visible at introitus, or we say head on the perineum. So basically बच्चे का head एकदम नीचे पड़ा है perineum पे. So when you are seeing head on the perineum or when the scalp is visible through the introitus, then when you apply forceps, it is outlet forceps. The third requirement is the sagittal suture should be in either AP diameter or in right or left oblique diameter. Right? So sagittal suture of the baby's head should be either in AP. AP is preferable or more important, but you can still apply outlet forceps if it is in the right oblique diameter or the left oblique. इसका मतलब अगर rotation complete नहीं है, yes, can you apply forceps? Yes, we can apply, but provided कितनी incomplete है? So if I draw this as the sagittal AP diameter and I am saying this is the sagittal suture of the baby's head. So I can apply the forceps when sagittal is not in AP, but only if it is in oblique diameters, which means this angle should be less than 45 degrees. We call it as rotational defect. So forceps outlet can be applied if the rotational defect is less than 45 degrees. समझ में आ गया सबको? So these are requirements for outlet forceps. Is it clear, bacha? This is important, right? Now, the second classification is low forceps. You call it as low forceps if the station is more than or equal to +2, but head is not on perineum. So perineum से ऊपर है अगर it is more than or equal to +2, right? So that is what is called as low forceps. Okay. Then there is a mid cavity forceps. Mid cavity किसको कहते हैं? If the head is between 0 and +2. So if it is between 0 and +2, it is called as mid cavity. और एक पुरानी क्लासिफिकेशन थी जिसमें हम हाई फोर्सेप्स भी बोलते थे. हाई फोर्सेप्स इज इफ द स्टेशन इज अबव 0. मॉडर्न ऑब्स्टेट्रिक्स में we are not actually doing a mid cavity and a high forceps delivery, right? So modern obstetrics में we are not doing a mid cavity or high forceps delivery, right? We are only doing outlet and low forceps. Is it clear? So we are only doing outlet and low forceps. ठीक है बच्चा? Is it clear? Okay. Now I want you to quickly have a look at some of the common forceps we use. So this is the most common one that you should know. So this is called as the Wrigley's forcep, right? So this is called as the Wrigley's forcep. ठीक है बच्चा? Now please understand the left blade. Okay, the left, so there are two blades, the left and the right, right? The left blade is introduced first. Okay, now why? This is because of the way the forceps is designed. अगर आप left blade पहले नहीं डालोगे, you will not be able to lock the forceps, right? So this is an unlocked forceps, right? So इसमें देखो एक है जिसमें ये socket बना है, right? So on one blade there is a socket. This blade has to go lower. ये lower तभी होगा जब आप इसको पहले डालोगे. So you introduce the left blade first, socket आ जाता है और फिर socket के ऊपर the other blade will fit like this. Such a kind of a lock is called as English lock, and this is what we use to identify a Wrigley's forcep, right? So this is called as a English lock, right? And this is how we identify Wrigley's. Okay, कल मैंने बताया था, is Wrigley's a short forcep or a long forcep? It is a short forcep, right? So it is a short forcep. Clear everyone? Okay. This is a longer forceps, as you can see, right? It is longer than Wrigley's. And look at the lock. Does it look like an English lock? No, this is called as a sliding lock. It can slide up and down the shank. Okay, so इसको shank कहते हैं. So it can go up and down, right? So this is the sliding lock. Why am I telling you sliding lock? जैसे ही देखोगे, you have to know that this is a key land forcep. Right? So this is a key land forcep. Key land forcep आजकल use नहीं होती. So practically you never see it around, but just have a basic idea that the one with the sliding lock is key land, and this is actually a rotational forcep. मतलब समझते हैं? If the rotational defect of the head is more than 45 degrees, तो हम पहले Wrigley's लगाते हैं. We will correct the rotational defect. Once the rotational defect is corrected, then I will apply Wrigley's. So this is actually a rotational forcep. Is it clear to everyone? Okay. This is the one that we saw yesterday. This is the longest out of the three. It is called as Piper. And I told you, how do you identify? This is the only forceps which has a reverse perineal curve, which is also called as pelvic curve. Right? So the only forceps that has a reverse perineal curve or a pelvic curve. And you know what it is used for? After coming head of breech. Yes, so after coming head of breech is where you use the Piper forceps. Yes, then this is another picture that I want you to see. So look at this. This is the sagittal suture of the baby's head, and this is the Wrigley's forceps. Now here in this picture, what we are trying to show you is what is correct application. Right? Because अगर आप correctly apply नहीं करोगे, the instrumental delivery will fail. Right? So what is the correct application? Ki once you have put the forceps and you've locked it, the blades of the forceps should be equidistant from the sagittal suture. Okay, so the blades should be equidistant from sagittal suture. Okay, is this clear to everyone? Right. Okay. Now, if you are using a outlet forceps, right? So if we are using an outlet forceps, what has to be the direction of pull? Okay. So पहला direction होता है forward, दूसरा direction होता है sorry. So the first direction is downwards, and then it is forwards. Right? Now, ये बहुत बार बच्चे confuse होते हैं कि ये कैसे decide हुआ. So look, assume this. This is a woman on the delivery table, right? And she's pregnant. Okay? Now, when you have to say the direction of movement, it is with respect to the woman, right? Not with respect to you. So, पहले आप बच्चे को नीचे बाहर खींचते हो, but this is down with respect to the woman, so downwards. And then because it is outlet forceps, उसके बाद कैसी movement होनी चाहिए? Upwards, right? So, आपके लिए upward है, मगर patient के लिए ये forward है, right? So, it is downwards and forwards. Is it clear to everyone? So, if it is an outlet forceps, it should be downwards and forwards. Alright? Okay, Sangameshwar wants to ask reverse pelvic curve. Okay, I'll go back. Let's look at this picture. Sangameshwar, ये बहुत बेसिक्स हैं बेटा. So although not required for entrance exams, मगर अगर आप प्रोफेशनल पेपर दे रहे होते या पोस्ट ग्रेजुएशन में होते तो मैं जरूर और डिटेल में जाती. But this is what I would like to tell you. See, normal forceps have a cephalic curve and they have a pelvic curve, right? So when we talk about this, look at this. Cephalic, first look at my hands. Look at my hands. Cephalic curve क्या है? The curve which is touching the head of the baby. So जो अंदर की तरफ है, ये cephalic है. And this curve जो ऐसे जा रहा है, yes? So this curve which is going along the perineum of the patient, right, is called as the pelvic curve, right? So this is what is normal. अब Piper में देखो, Piper में actually ये उल्टी दिशा में जा रहा है. Can you see this? So वहां पे वो ऐसे ऊपर से नीचे आ रहा था. Pipers में देखो कैसा है, नीचे से ऊपर जा रहा है. So that is why it is called as a reverse curve. Yes, Sangameshwar? Okay, right? So it is so a reverse pelvic curve or a perineal curve. So it has to go along the perineum. What did I write? Okay. Yes, मैंने नीचे लिख दिया. He was trying to correct me. That's very sweet of you. Thank you. So it's a reverse pelvic curve, or we call it as perineal curve. मैंने ऊपर नीचे कर दिया. Thank you so much. You know, there is something that I really like, and that is when I am teaching and when one of the students would suddenly correct me in between. Okay, and that really fills me with a lot of joy. If you are thinking why, because I presume कि मैंने तुम्हें इतना अच्छा पढ़ाया और तुम्हें इतने अच्छे से समझ आया कि now you're at a stage where you can correct me. So it actually fills me with a lot of joy, and it tells me that you're on the right path. It tells me that you understood things in the yesterday's class. So yes, मैंने ऊपर नीचे गलत लिखा है. So Sangameshwar was correcting me, and thank you for that, and all the best to you for it. Okay, great. Let's go further. So, telling you the direction of pull in the outlet. Okay, so it is going to be downwards and forwards. Is it clear to everyone? Yes? Also, sometimes पहले जब बहुत सारे वन लाइनर्स आते थे एग्जाम में, तो कभी कभी हम यहाँ पे इसके साथ ये भी पूछते थे, along which diameter? Okay, so along which diameter do you apply forceps? So when we ask you along which diameter you apply forceps, you have to answer it as occipitomental. Right? It is occipitomental diameter. All right? Yes? Is it clear to everyone? Okay. So especially, you know, we would ask you what is correct application. So you should be able to answer these. Right? Now, talking a few things that you should know specially about vacuum. Okay. So this is the vacuum cup that we use. So what I want you to know is that these days we use silastic or plastic cups. So it's made of a material which is called as silastic, right? As you can say, most of the times it is going to be bell shaped. Please remember, we are no longer using metallic cups. So usually they are bell shaped. They could be mushroom shaped as well, right? And they come in various diameters, but usually it will be between 2 to 5 centimeters. The most important thing that you have to know about the vacuum cup is where to apply it on the fetal head, right? So let's look at this. So you all know that the triangle is the posterior fontanel, the diamond is the anterior fontanel, this is the sagittal suture. Now, as you can see here in the image, that when you talk about, okay, when you talk about the cup, a correct application is that the cup has to be put on the flexion point, right? So, जो cup का center होता है, it has to be on the flexion point, right? Now, what is a flexion point? So, a flexion point is a point on the sagittal suture. Okay, so it is a point on the sagittal suture which is 3 centimeters anterior to posterior fontanel, or we say 6 centimeters posterior to anterior fontanel, right? So 3 centimeters anterior to posterior, or 6 centimeters posterior to the anterior fontanel. Now, do you think, so this dimension is 3 and this dimension is 6. But do you think I actually sit in the labor room with a scale and measure these centimeters and then I go and put the cup? No, right? So we actually do the reverse. हम पहले अपनी training से cup लगाते हैं and then we will check whether the cup is correctly placed or not. अब ये कैसे पता लगेगा लगाने के बाद? So देखो, जब आपने flexion point पे लगाया है, the cup perimeter is touching which fontanel? बताओ? So look at the picture and tell me, the cup perimeter is touching which fontanelle? The anterior fontanelle or the posterior fontanelle? So it is touching the posterior fontanelle. So when you apply it at the correct place, the perimeter of the cup should touch the posterior fontanelle. So it has to be applied close to the posterior fontanelle. Is it clear? Now, talking about why is it called as a flexion point? क्योंकि यहाँ पे जब आप लगा के pull करते हो, right? This ensures that the head of the baby stays in flexion. And why is flexion important? Because once the head is in flexion, we ensure that the smallest diameters are coming out. Okay. Now, what is the pressure generated by the vacuum? So it is around again 600 to 660 millimeters of mercury. अगर एक आंसर करना है तो you can answer it as 660, not a problem. Sometimes the same thing is asked in kgs per centimeter square, so then it has to be 0.8 kgs per centimeter square, right? So this is the pressure generated. Okay. Also, we would like to know from you all, when we talk about vacuum application, what would you call as a failed vacuum? So failed vacuum is, हमने कप लगाया, pressure increase किया. Remember that you are going to pull synchronous to a contraction. You don't pull in between contractions. You have to pull synchronous to the contraction. Okay. So if you have done 3 pulls, but there is no descent. So आपने पहली बार लगाया, pull किया, the head doesn't come down. Second बार फिर किया, third बार फिर किया. So 3 pulls and no descent of the head means it is a failed vacuum. Okay. There's another way where we say it is failed. If we say there are 3 cup pop-offs. What is a pop-off? आपने cup लगाया, pressure increase किया, and when the contraction was coming, you were about to pull, but the cup detaches. So the detachment is called as pop-off. So if there are 3 cup pop-offs, that is also considered as failed. Please remember, if the vacuum device fails, okay, so if the vacuum device fails, should I go now and apply a forceps? No. Never apply both instruments one after the other. If one instrument fails, you have to take the patient up for a cesarean section. Yes? What is the maximum time you can try with vaginal delivery if they ask you in terms of time? So maximum time for trial with instruments is 30 minutes. So if you are unable to deliver the baby within 30 minutes of instrumental delivery, please shift her for a cesarean section. So maximum that you're going to give it a try is going to be for 30 minutes. Now comes a very important thing, but I'm tweaking it towards the end so that it leaves a lasting impression on you. When we are saying we are going to apply forceps or vacuum, I did tell this yesterday as well, I'm repeating it. If there is a cephalopelvic disproportion, मतलब जगह ही कम है, so the cause is not exhaustion of the mother, the cause is not poor contractions, the cause is less space. Do you think you should be using any of the instruments? Should you be using instruments? बिल्कुल नहीं. So please remember, इससे पहले कि आप इंस्ट्रूमेंट लगाएं, you have to be sure that there is no CPD. Okay? Cephalopelvic disproportion. So CPD is a contraindication for instrumental delivery. Okay? Also remember, in HIV positive women, Okay, in HIV positive women, again, instrumental delivery is avoided. In fetal coagulopathy, again, instrumental delivery is contraindicated. Right? So presence of fetal coagulopathy or presence of fetal bony disorders, for example, osteogenesis imperfecta. Again is a contraindication for instrumental delivery. Yes? So you should know the contraindications. They are very important because this will help you decide कि cesarean करें या instrument के लिए try करें. Yes? Is this clear to everyone? Okay. Now once we know all these things about normal labor, abnormal labor, malpresentation, CPD and instruments, are we ready for a round of MCQs? Yes? Are we ready for a round of MCQs? Is this clear for everyone? Yes? Chalo, let's try and do this. So the first question is, your patient is 38 weeks pregnant. She's come with regular painful contractions every 3 to 4 minutes lasting 60 seconds. She is 3 centimeters dilated, 90% effaced, an amniotomy is performed and clear fluid is noted. The patient receives epidural analgesia for pain management. The fetal heart rate tracing is reactive. 1 hour later on repeat exam, she is 5 centimeters dilated and 100% effaced. What is the next step in her management? So tell me. So whenever you get a question, follow the same order that I told you. Okay, what is the order that I told you? First, see whether she is in true labor or not. Then see in which phase of the labor she is, first or second stage. In the first and the second, then see whether she is in active phase or latent phase. And then see whether it is normal or abnormal. So tell me, is this normal? Yes, this is absolutely normal progress. So within a span of, 1 hour, she has gone from 3 centimeters to 5 centimeters, right? So this is a normal progress of labor and therefore no intervention is required. Pushing abhi nahi karna, pushing is done at full dilatation only, right? There is no need for Pitocin. What is Pitocin? Pitocin is the other name for oxytocin, right? Do you need to do a cesarean section? Absolutely not, right? So the answer is C. Very good. Chalo aage karte hain. Your patient is 39 weeks pregnant. Okay. She is admitted in labor at 4 centimeters dilated. The fetal head is at 0 station. You perform clinical pelvimetry and find out that the diagonal conjugate is 10 centimeters. The interistitial spine is 11. The side walls are non-convergent and the intertuberous diameter is 9. How will you describe this pelvis? Yes, how will you describe this pelvis? Come on, tell me. So is it a normal pelvis? So no, this is not a normal pelvis, right? Intertuberous is 9, which is okay. So no problem with the outlets, right? Interspinous is 11. That is also fine. But when I say the diagonal conjugate is 10, how much will be the obstetric conjugate? How much would be the obstetric conjugate? DC minus 1.5. Yes, which makes it 8.5. And if you remember, we said if the obstetric conjugate is less than 10 centimeters, you will call it as a contracted inlet. Yes. So now you see कि कैसे हमने एक value based question को we have converted into a clinical question. Yes, can you all appreciate? So it was a value-based question, but we have converted it into a clinical question. Yes? So the answer becomes B. This is a contracted pelvic inlet, right? So the same thing, we can actually ask you, we may ask you, pelvic inlet is contracted if diagonal conjugate is less than how much? What would be the answer? Can you tell me? The inlet is contracted if diagonal conjugate is how much? Less than 11.5. Because the cutoff is 10 centimeters for OC. So in terms of DC, the answer will become 11.5. Is it clear to everyone? Okay, let's go on to the third question. So your patient is 39 weeks pregnant. She is presenting to us with ruptured membranes and 4 centimeters dilated. She has a history of 2 prior vaginal deliveries. Now over the next 2 hours, she progresses to 7 centimeters. 2 hours later, she remains 7 centimeters dilated. The estimated fetal weight is 3200. Which of the following labor abnormalities best describes the patient? What is the answer for this? So, what is the answer for this? So, please remember, is it a prolonged latent phase? No. Okay, the patient is in active phase. So, it's not a prolonged latent phase. Is it hypertonic dysfunction? No, she is not getting too many contractions. Yes? Is it a protracted active phase? Actually, yes. So, although यहाँ हम D लिख रहे हैं, मगर this is based on the newer guidelines. On the newer guidelines, to say that it is arrest, it should be how much? It should be an arrest of 4 hours. Yes? So, abhi 4 hours nahi hue hain, right? So, she remains, at 7 for 2 hours. So, as of now, it is a protracted active phase. Do you understand this? Abhi ye arrest nahi hai. यहाँ पे डी लिखा है इसलिए तुम गड़बड़ कर रहे हो. यहाँ पे डी गलती से लिखा है, वो ओल्डर क्राइटेरिया था. सो अर्लियर द क्राइटेरिया फॉर अरेस्ट वाज 2 hours. इट्स नो लॉन्गर 2 hours. Okay, the newer criteria for arrest is what we have to follow is 4 hours. Is this clear to everyone? So this is actually a protracted active phase. Is this clear to everyone? Protracted means slow. Okay. Chalo, let's look at the next one. So your patient is in the second stage of labor and an episiotomy is about to be cut. Compared with a midline episiotomy, which of the following is an advantage of mediolateral episiotomy? What is the advantage of mediolateral episiotomy? So, is it easy to repair? No. Fewer breakdowns? No. More breakdowns. More blood loss. More dyspareunia. So what is the answer? Less extension of the incision. Yes? Less extension of the incision. Is it clear? Okay. Right. Let's look at next one now. Your patient is 40 weeks. She is in active labor. 5 centimeters dilated. Vertex is at 0 station. She is in oxytocin augmentation. She has received an epidural for pain management. The nurse calls you. Okay. Because the fetal heart rate is in the range of 70 beats per minute lasting for 60 seconds. Okay, it is for past 3 minutes like this. The contraction is covering every 3 minutes lasting 60 seconds. Look at the vitals of the patient. The blood pressure is 90 by 50. The pulse rate is 105. On repeat examination, the vertex is well applied to the cervix and the patient remains 5 centimeters dilated. Which of the following is most likely the cause of deceleration? I'm removing myself so that you can read the question clearly. Right? So she has progressed, not right now, right? She was at 5, she's still at 5. What is the cause of her deceleration? Anybody? Anybody knows what is the cause? Okay. Is it oxytocin? No. She is getting only 3 contractions, which is okay. Is it placental abruption? Again, no. In placental abruption, we don't get these findings. We will get findings of bleeding, a tense abdomen, right? Is it a cord prolapse? No. That is something which would be evident to us when we do a PV exam. But we have done a PV exam, we didn't see a cord. Is it hyperstimulation? No. It has to be, for hyperstimulation, it has to be more than 5 contractions. So you have to remember that epidural analgesia, I told you one of the most important side effects of epidural is what? Is hypotension. And because of this hypotension, you come across fetal distress. So there is nothing to worry about here, right? So this is because of hypotension. You simply have to correct, give her fluids, and the fetal heart rate would be back to normal. Is it clear to everyone? Okay, let's go ahead and see the next one now. Your patient is 41 weeks. She has been pushing for 2.5 hours. She is a primigravida. The fetal head is at the introitus and begins crowning. It is necessary to cut an episiotomy and the tear extends through the sphincter of the rectum, but the mucosa is intact. Yes? So now, how would you classify this episiotomy? So what category is this? So, if the sphincter is torn but the mucosa is intact, it will be a 3rd degree perineal tear. Yes, this would be a 3rd degree perineal tear. Answer क्यों नहीं कर रहे हो सारे बच्चे? जल्दी जल्दी आंसर किया करो. Okay, so this is going to be a 3rd degree perineal tear. All right? Good, good. अभी आंसर कर रहे हो. Let's look at the next one. So this is again a lamba sa question, right? But once you know the concepts, things will not be difficult. I'm trying to highlight the keywords for you. So your patient is 38 weeks pregnant. She's come to labor and delivery, right? For the second time during the same weekend. She initially presented on Saturday at 2 p.m. complaining of uterine contractions. Her cervix was 1 centimeter dilated, 50 effaced. Now she has come again. So she was sent home. She has now come again on the Sunday at 8 p.m. So पूरे एक दिन के बाद, after 24 hours, she comes back again and she's saying she is having increasing pain. She is exhausted because she did not sleep the night before. Right? The patient is placed on an external fetal monitor. Contractions are occurring every 2 to 3 minutes. You re-examine the patient. The cervix is unchanged. Which of the following is the next management of the patient? Yes? So can you tell me what is this? Can you tell me what is this? So most likely this is going to be what? A false labor or latent phase of labor. Yes. So as of now, there is no change in the cervical dilatation as well. But we are saying that the patient is exhausted and she didn't sleep because of these contractions. I told you what is the management for whether it is false labor or it is latent labor? Rest and sedation. Yes. So rest and sedation. So that is going to be the best thing that you can do for this patient. Okay. So the answer here is going to be give her a strong sedative that will take care of the pain. If it is true labor, it will progress, right? But if it is false labor, the contractions will subside, right? How many of you think it should have been given an epidural? Can I administer her an epidural? The answer is no. भाई देखो एपिड्यूरल तभी लगाना है जब बहुत श्योर हो कि ये ट्रू लेबर है, राइट? क्योंकि एक बार एपिड्यूरल लगा दिया तो डिलीवर करना ही पड़ेगा, राइट? यू कैन नाउ टेक आउट द एपिड्यूरल एंड से गलती हो गई, राइट? सो हियर इट इज नॉट एपिड्यूरल, यू सिंपली गिव हर अ सेडेटिव. Putting an epidural is a commitment that delivery will take place. Is that clear, bacha? Okay. Let's look at this. Your patient is 37 weeks. She has come with rupture of membranes. Okay. She's having contractions. On examination, she is 4 centimeters dilated. A soft presenting part, which is fetal buttock, is swelled. Okay. Both hips are flexed and knees are extended. So do you see how we have converted a very simple, easy thing into such a long clinical question? What type of breech presentation is described? So this is easy. This is frank breech. Yes, since both hips are flexed and knees are extended, this is going to be a frank breech. तो वही मैं बोल रही हूँ, कई बारी आप सिर्फ लेंथ ऑफ क्वेश्चन से घबरा जाते हो, कोई घबराने की बात नहीं है. Just read it, cautiously. Most of the times, the longer the question, the easier it becomes actually. Okay? Right. Let's look at this one. Okay. So your patient is 41 weeks pregnant. She has come with gross rupture of membranes, painful uterine contractions. On digital examination, her cervix is 3 centimeters dilated. Fetal feet are palpable, right? The estimated weight is given, heart rate is given. What is the best way to deliver? So the only keyword here is one. What is the keyword? Fetal feet. Because it is a footling presentation, I told you footling is an indication for emergency cesarean section. You will not do an external cephalic version. You will not try a breech vaginal delivery, right? So इतने बड़े question में सिर्फ एक keyword चाहिए था मुझे, which is fetal feet, right? So footling would be an indication for what? For cesarean section. Yes? Okay. So the last one, and then we take a short break and then we go over to the postpartum phase. So let's see this question. Your patient is 38 weeks, 6 centimeters dilated, ruptured membranes. On examination, fetal nose, eyes and lips are palpated, right? The heart rate is given to you. There are no decelerations. The pelvis is adequate. What are you going to do for her? So, we are saying what presentation is it? It is face presentation. Yes? So now what do? Perform immediate cesarean without labor. Do you do that? No. Right? No. Why? Because we said majority of times when it comes to face, they are going to be mento-anterior. And if they are mento-anterior, they will deliver vaginally. So just because it is phase presentation does not mean you will do a cesarean section unless we specify that it is a persistent mento-posterior. Okay, so unless we specify it is persistent mento-posterior, right? Darshit, latent phase में arrest नहीं होता बेटा. Arrest is a diagnosis only and only in the active phase, right? Darshit, latent phase में arrest diagnosis नहीं होता. It has to be in the active phase and it has to be for 4 hours. मैंने बोला 2 hour पुराने criteria हैं. नया criteria is no change in cervical dilatation for 4 hours. Is it clear, bacha? Yes? Okay, so those are the questions that we have done. We will do some more once we do the postpartum phase as well. Okay, so should we take a short break? Yes? So we will start the class at 6:15. All right? And then we will move on to the postpartum phase. Okay? So 6:15 we will restart the class. If you have any doubts, you can ask in the chat box. You can ask it after we start again. All right? Here, they will deliver vaginally. So just because it is phase presentation does not mean you will do a cesarean section unless we specify that it is a persistent mento-posterior. Okay, so unless we specify it is persistent mento-posterior, right? Darshit, latent phase में arrest नहीं होता बेटा. Arrest is a diagnosis only and only in the active phase, right? Darshit, latent phase में arrest diagnosis नहीं होता. It has to be in the active phase and it has to be for 4 hours. मैंने बोला 2 hour पुराने criteria हैं. नया criteria is no change in cervical dilatation for 4 hours. Is it clear, bacha? Yes? Okay, so those are the questions that we have done. We will do some more once we do the postpartum phase as well. Okay, so should we take a short break? Yes? So we will start the class at 6:15. All right? And then we will move on to the postpartum phase. Okay? So 6:15 we will restart the class. If you have any doubts, you can ask in the chat box. You can ask it after we start again. All right? Right. So now, as we move towards the end of pregnancy, right, we are going to talk about the postpartum phase of the woman. Okay? Now, when we talk about the postpartum phase, what do you think is the most important thing that we have to talk about? किस बारे में बात करना है? So the most important thing that we have to talk about is postpartum hemorrhage. Yes? Now, how do you define postpartum hemorrhage? So, you know, postpartum hemorrhage is defined as bleeding which is more than 500 ml after vaginal delivery and more than 1000 ml after cesarean section. Right? So that is the standard definition of postpartum hemorrhage. Right? Now, although this is, yes, the standard definition of postpartum hemorrhage, right? There are other definitions that we need to know as well. Okay? For example, when we talk about postpartum hemorrhage, one of the most important definitions is primary and secondary. Yes? So, primary hemorrhage is if it happens within 24 hours of delivery. Right? Whereas secondary hemorrhage is if it happens beyond 24 hours up to 12 weeks postpartum. So it's not 6 weeks, it is up to 12 weeks postpartum. That's when we say that it is secondary hemorrhage. Right? Now, if you understand this, when we talk about bleeding more than 500 ml or more than 1000 ml, it becomes very difficult to assess the amount of blood loss. It becomes very difficult to assess the amount of blood loss. So actually a more practical application or definition of postpartum hemorrhage is bleeding that results in signs and symptoms of hypovolemia in the patient, right? So it is bleeding that would result in signs and symptoms of hypovolemia in the patient is what we would describe as postpartum hemorrhage, right? Now, why are we talking about PPH and why is it so important for us? So when we talk about postpartum hemorrhage, it is important for us because we have to know that it is one of the leading causes of maternal mortality, right? So PPH is one of the leading causes of maternal mortality. Okay? And therefore, what we want to do is, we want to diagnose PPH, at a very early stage so that you reduce the morbidity and mortality. See, not every time can you prevent PPH, but if you are more alert, right, and if you're able to diagnose it at an early stage and you start interventions at an early stage, you will reduce the morbidity and mortality, right? So if you really want to pick up postpartum hemorrhage in an early stage and you want to try and prevent it, what are you going to do? So the first thing is that as clinicians, we have to know who are the women who are at high risk of developing postpartum hemorrhage, right? So what are the risk factors for postpartum hemorrhage? Now the first thing that I want you all to know is that whenever there is prolonged labor, अगर लेबर बहुत लंबा चलेगा तो PPH is more likely. Why? So एक general concept समझते हैं. If you are stretching the uterine muscles for either long duration or overstretching them, then reflexly it takes time for these muscles to contract and come back to the original length. So if they are stretched more or if they are stretched for more duration, then the likelihood of PPH is increased. So all these conditions which can cause prolonged labor will be risk factor for postpartum hemorrhage. Not just prolonged, also even if the labor is too short, so something that we call as precipitate labor. So precipitate labor is when the entire process of labor happens within 3 hours, right? So if the entire process from the onset to the expulsion of the baby, if it happens within a short phase of within 3 hours, it will be called as precipitate labor. Now the reason for precipitate labor here is not overstretching, but it's actually trauma to the genital structures. So if the baby is going to come out so quickly, it's going to cause more trauma to the genital structures. So this is more likely going to be a traumatic bleeding that's going to happen, right? Then as I said, if you are overstretching the uterine muscles, which means over distension, for example in polyhydramnios, right? For example in multifetal pregnancy, for example in a macrosomic baby, right? These would also be risk factors for postpartum hemorrhage. Is this clear to everyone? Yes? So, over distension of the uterus is going to be a risk factor for PPH. Then any time a woman has antepartum bleeding, she is at a higher risk of having postpartum bleeding as well. For example, women with placenta previa or abruption are at a higher risk of having postpartum hemorrhage, right? Then you all know we have already talked about adherent placenta as well. How if you don't diagnose it antepartum, how it can cause, postpartum hemorrhage. So morbidly adherent placenta like accreta, increta, percreta. Okay. Then another important risk factor for postpartum hemorrhage is preeclampsia or hypertensive disorders of pregnancy, right? So preeclampsia and hypertensive disorders are risk factors because you know the entire pathophysiology. They have a contracted blood volume. So even if they lose small amount of blood, right, they are going to be much more symptomatic. They also have abnormalities of platelet function, platelet number, right? So they are again risk factors for postpartum hemorrhage. Then we have seen that induced labor as well as augmented labor. So जब आपने induction किया है या आपने augmentation किया है, that also increases the risk of PPH as compared to normal labor. Obviously, yes, instrumental delivery. Why? Because majority of times instrumental delivery is being done in prolonged labors, so there is anyways higher risk. And then application of instruments can cause trauma, which can again cause bleeding. So instrumental delivery. Uterine infection, very, very important here is chorioamnionitis. Right, so chorioamnionitis is also an important risk factor for postpartum hemorrhage. Right, sometimes just the presence of multiparity. So we typically say grand multipara, right? So or multipara in general. So multiparity also increases the risk of postpartum hemorrhage, right? So grand multipara is more than or equal to 5, but yes, as parity increases, the risk of PPH is going to increase, right? So these are all important causes. Lastly, yes, if a woman has fibroid uterus, again she is likely to bleed more during the course of her pregnancy. So as I said, the reason why we want to know this the risk factors is because we want to pick up PPH at an earlier stage and reduce the morbidity and mortality. So if I know who are the women at high risk, I can give more attention to them and I can diagnose it earlier. Now, ये सारे तो risk factors हैं, but how is PPH actually happening? So when we talk about what is the mechanism of blood loss, or in other words, what is the cause of blood loss, then there could be 4 ways on why a woman is bleeding. Risk factor अलग चीज हो गया, मगर bleeding हो कैसे रहा है? So one is what? One is uterine atony. So as I said, the uterus or the muscle fibers remain relaxed. They are not going to contract and therefore they do not occlude the blood vessels. Generally, do you know that it is actually the middle layer of the myometrium? Right? So the middle layer of the myometrium acts like a living ligature. Why? Because this middle layer of the myometrium, the muscle fibers are arranged like this. They are arranged in a crisscross manner. So when they are arranged in a crisscross manner, यहाँ पे ये blood vessels हैं. When the muscle fibers will contract, they will occlude the vessels and they will stop the bleeding. But if these muscle fibers don't contract, these vessels will remain open and they will bleed. So uterine atony is actually in general the most common cause, right? So among the causes, it is going to be most common cause of PPH in general. Then the second leading cause is genital tract trauma. right? So the second mechanism on why or how the woman is bleeding is trauma to the genital tract. Third is retained placental tissue. Now please understand, when I say it is retained placental tissue, we don't mean that it's the entire placenta. A lot of times it's only parts of placenta which are left behind. So please listen to me very carefully and look at me for a moment. Let's presume my fist is the cavity of the uterus. Uterus ka general tendency I taught you is, if you put anything in its cavity, it is going to try and contract and expel it. So this is what happens if placental tissue is left behind. So what will the uterus do? It will contract and try and expel the placenta. Magar agar nahi niklega, it will reflexly relax and then bleed. So बीच-बीच में contractions आएंगे और बीच-बीच में relaxation होगा और bleeding होगा, right? So if placental tissue is left behind, it is going to be one of the causes of bleeding. This is typically seen with a placenta which is called as placenta succenturiata, right? So placenta succenturiata, इसमें क्या होता है? There is a bigger lobe of the placenta and there is a smaller lobe, and the smaller lobe is connected to the bigger lobe by blood vessels, whereas the umbilical cord is attached to the bigger lobe, right? So this is, we call it as the succenturiate lobe. तो इसमें क्या होता है, कई बार the bigger placental unit comes out, मगर ये छोटा वाला is retained, and then it will cause PPH. The thing that I want to highlight here is that this smaller lobe is not a part of the bigger lobe. तो मुझे बताओ, when you will examine this placenta जो निकला है, will it look complete or will it look incomplete? Can you tell me this? So I'm asking you कि ये छोटा placental tissue अंदर रह गया है, बड़ा वाला बाहर आ गया. So when you're examining this placenta, will it look complete or will it look incomplete? So please remember, this placenta will look complete. Yes, because chota wala is not a part of it. So despite the fact that the placenta on expulsion looks complete, is it possible that a tissue is retained? Yes or no? Yes. So even if placenta looks complete, there is a possibility that the tissue is retained. Right? So there is a possibility that the tissue is retained. Yes? And this, although is not very common, but it is possible. So the possibility is with succenturiate lobe. Okay? It's not a very common thing, but you should know that there is something like this which can happen. And the last mechanism of bleeding or cause of bleeding is problems with coagulation. Right? So if there is a coagulation failure, then yes, the woman can land up with PPH as well. Right? So these are the 4 causes, and we call them as 4 T's. Right? So you will remember them as 4 T's. Tone, trauma, tissue, thrombosis. Right? So tone, trauma, tissue and thrombosis. Right? So that's how you should remember it. Now, once you know these 4 causes, this is generally what we also want you to know. Remember that the most common cause of primary PPH is uterine atony. Right? So the most common cause of primary PPH is uterine atony, whereas the most common cause of secondary PPH is retained placental tissue. Right? So the most common cause of secondary PPH is retained placental tissue. Right? Now, before I go on to how do you manage PPH, I will first talk about how you're going to prevent postpartum hemorrhage. Yes? So now you're going to tell me, before I go on to prevention, I told you that labor also has a third stage. So we have so far done the first stage of labor, we have done the second stage of labor. There is a third stage of labor as well, which is the stage of placental expulsion. Alright? Now, remember that the average duration of this stage is 15 to 20 minutes. You call it as retained placenta, okay, right, or prolonged third stage if it goes beyond 30 minutes. So average is 15 to 20. मगर अगर 30 minutes से ऊपर हो गए हैं, then you should suspect retained placenta, right? Now, who can tell me the causes of retained placenta, right? And also tell me, before you tell me causes of retained, how do you get to know that it is retained or it's coming out? So in other words, what are signs and symptoms of placental separation? So I am sure this is something that you've read before, but I would really want to highlight some basic things here. So one is a sudden gush of blood, right? The second is lengthening of the cord. The third is a suprapubic bulge. Right? Now let's understand this. Why is there a gush of blood? Because placenta separates from the decidua, the venous sinus is open and there's going to be bleeding. Why is there a suprapubic bulge? Placenta ऊपर से separate होके lower segment में आ जाता है. So it comes into the lower segment and as a result of which you see it as a suprapubic bulge. Why is there a lengthening of the cord? It is on the same concept. Placenta ऊपर से नीचे आ गया. So to the clinician ऐसा लगता है कि बाहर cord लंबी हो गई. But can you tell me, is it really a lengthening of the cord? So this is not true lengthening. This is only a apparent lengthening. असली में कॉर्ड की लेंथ नहीं बढ़ रही है, वो नीचे आया है इसलिए ऐसा लग रहा है कि लंबा हो गया. सो एपरेंट लेंथनिंग एंड दिस इज परमानेंट लेंथनिंग. मतलब एक बार लेंथनिंग हो गई वापस छोटा नहीं हो सकता, बिकॉज द कॉज इज द प्लेसेंटा कमिंग डाउन. सो इट्स परमानेंट एंड इट्स एपरेंट, राइट? Who is going to tell me what happens to the fundal height with placental separation? What happens to fundal height? The fundal height is going to increase, not decrease. देखो क्या होता है, when placenta separates and comes down into the lower segment, it pushes rest of the uterus upwards. So placenta खुद नीचे गिरा और उसने uterus को ऊपर उठा दिया, right? So that is why the fundal height actually increases. Now I want to know from you, out of all the 4 signs that you have written here, gush of blood, lengthening, suprapubic, fundal height, can you tell me out of all these 4, which of these would be most reliable sign of placental separation? So out of these, which is going to be the most reliable sign? So out of these, the most reliable sign is lengthening of cord. Because it is indirectly telling you कि भाई placenta नीचे आ गया है, so वो separate हुआ होगा तभी तो नीचे आया है. Yes, so out of these 4 it is lengthening of the cord. But can you tell me, is there something which is even more reliable than lengthening of the cord? Yes, so is there something that is even more reliable? And that is if you see placenta lying in vagina. So if you are seeing कि placenta vagina में पड़ा है, तो this is a direct evidence that it is separated, right? Lengthening of cord is an indirect evidence, but this is a direct evidence. So placenta lying in the vagina. Is it clear to everyone? Yes? Okay, becomes a better answer if in the options, if you see lengthening of the cord. Now, coming back to what I started with, I said retained placenta is something that happens if it's not coming out after 30 minutes. But what do you think would be the cause? So देखो, एक reason for retained placenta हो सकता है that placenta has separated but retained. मतलब it has separated from the decidua लेकिन बाहर expel नहीं हुआ, right? But do you understand that there is another possibility, that which is placenta not separated? When will this happen? If it is adherent placenta, right? So if it is adherent placenta, वो separate ही नहीं होगा. और तीसरा है entrapped placenta, right? So because of the formation of a constriction ring, right, the placenta is trapped inside, okay? And I want you to understand that these are these three possibilities because हर चीज का मैनेजमेंट अलग है. You cannot have a single management of retained placenta, right? इसमें से सबसे कॉमन क्या है बताओ? The most common of these is that placenta separate हुआ है मगर expel नहीं हुआ, which is because of, you know, probably inadequate contractions or things like that. इसीलिए generally speaking, if placenta is not separated, right? So, which means if you are seeing no signs of placental separation, सबसे पहले हम क्या करते हैं? You start oxytocin, right? Why? Because these uterine contractions will ensure that it gets separated and it gets thrown out as well. क्योंकि वही सबसे कॉमन कारण है कि वो सेपरेट होके एक्सपेल नहीं हो रहा, right? And this is what you will do between 15 to 30 minutes. So average time is 15 minutes. जब आपको लगता है कि प्लासेंटा सेपरेट नहीं हो रहा है, you are not seeing the signs of separation, you give oxytocin. ठीक है? Now please understand, if it is beyond 30 minutes, what you should go ahead and try is manual removal of placenta. So beyond 30 minutes, no more trial of oxytocin, right? So oxytocin is what you are anyways going to do in the third stage. I will just teach you, right? So वो तो आप वैसे ही कर रहे होते हो. Once 30 minutes have passed by, right, now you have to go in for a manual removal of placenta. इस टाइम पे आपको पता लगेगा कि क्या वहां पे कंस्ट्रिक्शन रिंग है, क्या वो एडियरेंट प्लासेंटा है, और क्या वो सिर्फ वहां पड़ा था एंड आई हैव टू जस्ट पुल इट आउट. आर यू गेटिंग मी? राइट? सो इफ इट इज अ कंस्ट्रिक्शन रिंग, मैनुअल रिमूवल के टाइम पे आपको वो रिंग फील होगा. If it is an adherent placenta, as I have taught you, you will not find a plane of separation, right? So beyond 30 minutes, you are going to do a manual removal of placenta. Please remember, this is a procedure which is done in OT and it is done under general anesthesia, right? So it is done in OT and it is done under general anesthesia. Can you think of the reason why? Why? Because you have to put your hand inside the woman's uterus, go into the space between the placenta and the decidua, and then with the ulnar border of your hand, with these slicing movements, you will try and separate. So it's an intrauterine procedure. You have to have the woman completely relaxed, right? And there should be no pain. So it is a procedure that we do under general anesthesia in the operating room. Is this clear to everyone? Yes? Okay. Adherent placenta में क्या करते हैं वो हम already कर चुके हैं. You will have to go ahead with a hysterectomy. If it is a constriction ring, तो क्या करना पड़ेगा? Tocolysis देना पड़ेगा. So if you put your hand inside and you feel कि हाथ नहीं जा रहा है because the lower segment has formed a constriction ring, then you give tocolysis, right? Make the uterus relaxed and then try the separation. Is it clear to everyone? Okay. Now, once we know what is normal and as we are moving towards abnormal, let's talk about what all can we do as clinicians to prevent pre-PH. Yes, what all can we do to prevent postpartum hemorrhage? Yes, so this is something that we said would universally be done for all deliveries. It is called as active management of third stage of labor. So please remember, AMSL is prevention, or in other words, prophylaxis for PPH. It is not management of PPH, okay? It is prophylaxis for PPH. And as I said, this is something we do universally. We will do this for all deliveries, right? AMSL is given by WHO. So WHO ने ही सबसे पहले AMSL दिया था, फिर WHO ने ही उसको modify भी किया था, right? So what are the current inclusions when you say you're going to do a AMSL, right? So first is give oxytocin immediately after delivery of the baby. Right? So give oxytocin immediately after delivery of the baby. Right? Which means oxytocin is the drug of choice for prophylaxis of PPH. Right? When you say immediate, this has to be given within 1 minute of delivery. Right? So when we say immediate, it has to be within 1 minute of the delivery. How much oxytocin do we give? So we will give 10 international units IM. Okay, so 10 international units IM. But remember, it can also be given IV. काम की बात क्या है? If you give IV, you will give it as a infusion. Never give it bolus. So bolus नहीं देना है. You will give it as an IV infusion, right? Bolus क्यों नहीं देते हैं? Because when you give large doses of oxytocin as bolus, it will cause hypotension. So IV bolus नहीं देना है. You will give it IV infusion. Yes? Okay. Now, a few things that you should know about oxytocin is that it is a nonapeptide. So please remember, the natural oxytocin is actually a nonapeptide, and I know that you would know that it is released from where? Posterior pituitary, right? So it is released from the posterior pituitary, but it is not synthesized there. It's only stored in the posterior pituitary. So where is it synthesized? Paraventricular nucleus, right? So paraventricular nucleus is where it is synthesized. It has an extremely small half-life. The single best answer is 3 minutes, but it could be a range of 3 to 5 minutes, right? Do you know that we have synthetic preparations of oxytocin? Yes, like syntocinon, like pitocin, they are synthetic formulations. Yes? So, just remember this, that when you talk about synthetic formulations, they are octapeptides. So, synthetic ones are octapeptides and will have a longer half-life. the 3 minutes is the half-life for the natural one. So for octapeptides, the half-life can go up to 30 minutes. So they will have a longer half-life. Okay. Now, where is oxytocin stored? Anyone? So ideally, it has to be stored under refrigeration at a temperature of 2 to 8 degrees, right? So ideal is refrigeration. It's not room temperature. That's very important. अगर आपको लगता है कि ये these are factual things and not important, then they are very important clinically. WHO especially ये कहता है that if you are transferring oxytocin to a third tier city or a periphery, the cold chain has to be maintained. Okay, otherwise it will not be an effective preparation. Yes, is it clear to everyone? Okay. Can any one of you tell me another name for oxytocin? कोई और नाम है इसका? So unrelated to PPH, but yes, you should know that it is also called as milk ejection hormone. Right? It's also called as the milk ejection hormone or milk letdown hormone. Do you know why? Why? Because the lactiferous ducts are lined by myoepithelial cells, है ना? So जो lactiferous ducts होती हैं, they are lined by myoepithelial cells. और oxytocin क्या करता है? It will cause the contractions, and once it causes the contractions, it will let the milk out. So a milk letdown hormone. Whereas yes, Peterson is also right, but this is what I wanted to ask here. And which is the milk synthesizing hormone? That's prolactin. है ना? That is going to be prolactin, right? Okay. Oxytocin is definitely the drug of choice for prophylaxis, but can other drugs be given? So, what are the other drugs we use for prophylaxis? So what are the other drugs that we use for prophylaxis? So we can also use methergin. What is methergin? It's methyl ergometrine. The dose is 0.2 milligrams given IM. Please remember preeclampsia or eclampsia, heart disease or peripheral vascular disease, right? So preeclampsia, eclampsia, heart disease, peripheral vascular disease, these are important contraindications of methergin. Do you know the reason why? मैंने पिछली क्लास में बताया था, when I did heart disease with you, so I said methergin causes transient but severe hypertension. So it should not be given in these conditions. Also remember that methergin comes in brown colored ampules. Right? Why? Because this is photosensitive. So you should keep it away from sunlight or direct light, and preserve it at a cool place. So it is photosensitive. Okay? No. Asthma में दे सकते हैं. I will tell you where you need to be careful about asthma. Okay? So this is methergin. Another drug that is a combination of oxytocin and methergin is sintometrine. Okay, so sintometrine is 5 units of oxytocin and 0.5 milligrams of methergin. Is it going to be more potent than oxytocin alone or methergin alone? Yes, दोनों का combination है, so obviously this is more potent. But what is the problem? That this is not easily available. and also it is going to be more expensive. है ना? So it is going to be more expensive than oxytocin. It is not easily available, इसलिए it is not the drug of choice, but yes, it can be used. Then you have to know another drug which is called as carbetocin. Carbetocin is a synthetic oxytocin analog. So it is a synthetic oxytocin analog. So octa or nonapeptide, क्या होगा ये? So this is going to be octapeptide. Yes, right? It can also be used. The dose is 100 micrograms. Okay, and it is given slow IV over 1 minute. Carbetocin. Carbetocin specially बोला गया है can be used as prophylaxis of PPH during cesarean sections. Right? So that's where they have initially used and tried carbetocin. Right? So 100 micrograms, slow IV over 1 minute. The last drug that you should know that we can give is misoprost. Right? You all know it is a PGE1 analog. है ना? So misoprostol का dose है 600 micrograms oral. So for prophylaxis, it is 600 micrograms given orally, right? What is one thing which is very characteristic to misoprostol as compared to above drugs? Can you tell me? ऐसा क्या खास है miso में as compared to the other drugs? So is it more potent? No. Okay, it is less potent. But क्या खास बात क्या है? This is the only drug out of the ones that we have written that is available as a tablet, right? So for this, the woman does not really need a doctor or a nurse. So आजकल जो government ने शुरू किया है, government कह रही है that you should actually distribute misoprostol tablets in third tier cities to these women so that they know that after delivery they can take these tablets as prophylaxis. So very, very important. So misoprostol is a tablet. Yes, less potent than oxytocin or methergin, but yes, where the women do not have access to the IV or IM drugs, वहाँ पे this is very, very essential to prevent PPH. Is it clear? Yes, Amar, routinely. In fact, that's what I'm saying. Government, WHO कह रहा है इसको और ज़्यादा हमें propel करना चाहिए because this is something that women can take by themselves. So even if they are delivering away from the hospital, right, they can take it themselves. Yes? Okay, so this was the first component of AMZEL, which is give a uterotonic agent immediately after delivery of the baby, right? What is the second component of AMZEL? Now, when it comes to the second component of AMZEL, it is controlled cord traction. So this is a method of delivery of placenta. So controlled cord traction, or popularly called as CCT. Now understand why it is called as controlled. Ek haath, my right hand is going to pull the cord. So one hand is going to give cord traction. Can you tell me what is the other hand going to do? So the other hand is kept in the suprapubic region and the fundus is pushed up. So in the opposite direction, that's a counter traction. So cord को नीचे खींच रहे हैं, fundus को ऊपर push कर रहे हैं, right? Can you tell me what is the importance of controlled here? Please understand that if you are, if the delivery is not being done by a trained person, right? What is the problem? The problem is that they will only give cord traction and not give the counter traction. So if you don't give this counter traction, what will happen? this can cause uterine inversion. Very good, Ayushi. Yes. Right? So, uterine inversion. Right? और इसीलिए to prevent this inversion, we should always give a counter traction. तो government या WHO guidelines क्या कहती हैं? CCT will only be practiced if there are, so only to be done in the presence of trained birth attendants, people who know how to do this maneuver. If trained birth attendant is not available, don't do a controlled cord traction. Okay? Then the third component of AMSIL is delayed cord clamping. So yes, universally it has to be a delayed cord clamping. This is what is to be followed as a universal guideline. When we say delayed, it means beyond 1 minute of delivery, right? It means beyond 1 minute of delivery, right? What is the advantage? The advantage is extra blood going to the baby. So approximately 80 ml of extra blood goes to the baby. This will also help supply extra iron to the baby, right? A common doubt which students would repeatedly ask is, ma'am, early kab karna hai, right? So, early cord clamping is only to be done under very specific conditions. One of the best ways to know whether you do early or no is to see whether the baby needs resuscitation or not, right? So if the baby needs resuscitation, it's a compromised baby at birth और उसको resuscitation की जरूरत है, then yes, you should do an early cord clamping. ठीक? दूसरा, RH negative. Please understand another thing. When I say RH negative, this is when the pregnancy is not immunized, allo-immunized. आप मेरे साथ RH negative पूरा पढ़ चुके हो, मुझे बताओ what is the meaning of not allo-immunized? What is the meaning of not allo-immunized? I hope all of you are able to give me the correct answer. Jaldi batao. What is the meaning of not allo-immunized? It means her ICT should be negative or positive? ICT negative. तो early cord clamping का फायदा तभी है जब she is ICT negative. Do you think there is any point in doing an early cord clamping if it's an ICT positive pregnancy? दिमाग लगाना है. तो इसीलिए मैं कहती हूँ रट्टा नहीं मारना है. So many of you are just, mugging up the points, and the problem is if you mug up the points and you don't know the why behind it, people on the internet are going to make a fool of you. They will keep teaching you XYZ things from the internet, and half of it is wrong. Yes? So please understand that if ICT is positive, अगर वो पहले ही allo-immunized है, तो early cord clamping करके क्या बचा लोगे भाई? Right? So early cord clamping will make sense only if the ICT is negative. If she is an ICT positive mother, she is already immunized. तो आप कम से कम बच्चे को तो benefit दो, right? So if it is ICT positive, you will do a delayed or early. You will do a delayed cord clamping. ठीक? So रटना नहीं है, समझना है. All right? The third indication is baby is a known case of heart disease. Right? So if the baby is a known case of heart disease, you don't want to overload the baby's heart. Right? And therefore, you will do a early cord clamping. These are the only indications for early cord clamping. Please understand, HIV में it has to be a delayed cord clamping. This is what is a WHO guideline, and this is also what is in the AIMS protocols, right? COVID may be delayed करना है. So COVID in pregnancy is no indication to do a early clamping. So whether it is HIV, whether it is COVID, right, we are all going to follow the universal protocol, which is delayed cord clamping. Is this clear? Now listen to me again. Routine uterine massage. Right? Routine uterine massage is not a component of AMZEL. So the key word here is not. Okay? It is not a component of AMZEL. Why? Why AMZEL is something that we are doing for prophylaxis. जब आप सबको ऑक्सीटोसिन दे ही रहे हो, there is no need to do a massage as well. Okay? So massage is not a component. What is a component on the contrary is that you should do intermittent uterine tone assessment. Okay, so intermittent uterine tone assessment. What does it mean? कि आपको बीच बीच में जाकर सिर्फ यूट्रस को हाथ लगा के देखना है whether it is well contracted or not. The intermittent, what we mean here is the WHO guidelines say do it every 15 minutes in the first 2 hours. So after every 15 minutes, you can go and just look at the uterus, whether it is contracted or not. This is done to early pick up atonicity. Is this clear? So I hope you all will not make mistakes in AMZEL और बार बार इंटरनेट से नहीं पढ़ोगे. ठीक है? Is this clear? जो मैंने बता दिया, I take full responsibility of what I am teaching you. Are you clear on this? Yes? Okay. What is the opposite of AMZEL? So थर्ड स्टेज का एक मैनेजमेंट का तरीका है AMZEL और थर्ड स्टेज का एक और मैनेजमेंट का तरीका है फिजियोलॉजिकल मैनेजमेंट. Physiological management of third stage is actually just the reverse of AMZEL. और हमेशा अगर आप देखोगे there is always a controversy between guidelines. So they keep saying, कभी बोलते हैं पुरानी चीजें ठीक थी और फिर बोल देते हैं suddenly नई नई अब नई आ गई, फिर वापस बोलते हैं नहीं पुराना ही अच्छा था. Just like we are also going from back to basics. So we talk about, suddenly we talk about science and technology and vaccines, and then suddenly we talk about Gaumutra, or we talk about other forms of alternative forms of treatment. So here also this push and pull has always remained between active management करना चाहिए या physiological management करना चाहिए. Right? So active, WHO कहता है active करना चाहिए, हमारी भी पहले guidelines कह रही थी active करना चाहिए, then बीच में the government started saying no, you should do a physiological management. Right? Yes, Disha, intermittent tone assessment is a part, okay, but massage is not a part. ठीक है बेटा? Okay. So when I say physiological management is just the opposite, what does it mean? It means no oxytocin to be given until spontaneous delivery of placenta. राइट. सो ये कह रहा है बिल्कुल उल्टा, ऑक्सीटोसिन नहीं देना जब तक प्लासेंटा सेपरेट नहीं हो जाता, और वो भी स्पॉन्टेनियस, नो कॉर्ड ट्रैक्शन. दूसरा क्या कहता है, नो कॉर्ड क्लैंपिंग टिल spontaneous delivery of placenta, right? So इसीलिए, as I said, just remember that the physiological management is just the reverse of active management. But what we say is to be done for prophylaxis of PPH is what? Active management. I just want you to know what is physiological management. Is this clear with everyone? Okay. I want to ask you, by doing active management, क्या ये पक्का है कि PPH नहीं होगा? So if you are doing active management in your patient, is it for sure the patient will not develop PPH? No, right? So please remember, we are reducing the chances of PPH, but your patient can still develop postpartum hemorrhage, right? So remember this, by giving oxytocin, you are reducing the risk by 50%, okay? So the most important component of AMZEL, अगर कोई आपसे पूछे, right, then this is giving oxytocin. This reduces the risk of PPH by 50%. मगर zero नहीं कर देता, okay? So it is reducing the risk of PPH by 50%. So which means, that is why I said, you and me as clinicians should always know which women are at high risk, ताकि हम उन पे ज्यादा ध्यान दें, और अगर PPH हो तो उसे जल्दी डायग्नोज कर लें, राइट? वाई? बिकॉज द फर्स्ट आवर, ओके, द फर्स्ट आवर फ्रॉम ऑनसेट ऑफ PPH is called as the golden hour, right? So the first hour from the onset of PPH is called as the golden hour. You must start the resuscitation of the patient and the interventions in this first hour itself if you want to reduce the morbidity and mortality. Is it clear to everyone? Yes? So jaldi pakadna, diagnose karna zaruri hai, right? So now we will shift on to management of PPH. So अभी हम कर रहे थे prophylaxis या prevention, अब हम करेंगे मैनेजमेंट. Okay? Now, again I'm going to go back to basics. Something that I have taught you before, but I would want to tell you again is, when we talk about postpartum hemorrhage or such complications, I always tell my students that there are two limbs of management, and in fact I've given you the two limbs pehle. One is something that you do symptomatic, and one is something that you do specific. Symptomatic stuff is done to reduce morbidity and mortality, while specific treatment is done to stop bleeding. Both are important. They should both be initiated side by side. Okay, ऐसा नहीं कि पहले ये करोगे फिर वो करोगे. No. And this is exactly why we say that when you come across PPH, one of the first things that you should do is call for help. The more people you have, the more likely is you're going to be more effective as a team to prevent mortality, right? So I must call for help. I will need more hands, right, in managing a woman with PPH. और अगर एक बार आपने सच में अपनी इंटर्नशिप में या लेबर पोस्टिंग्स में एक पीपीएच का पेशेंट देखा होगा, तो आप कभी नहीं भूलोगे कि क्या करना होता है। और आप अगर आपने एक भी मॉर्टैलिटी देखी है बिकॉज ऑफ पीपीएच, then you will never ever forget in your life that PPH is something जिसमें you can go all out and still lose the patient, right? So हम लोगों के hospitals में we used to run PPH drills for our postgraduates or undergraduates as well who were there with us in internship. So हम उनको ना ऐसे PPH drill क्या होता है, हम उनको ऐसे झूठ मूठ बोलते थे कि इस पेशेंट को PPH हो रहा है और हम लोग सब मिलके एज ए टीम वो सब करेंगे जो हमें करना हो इफ शी रियली हैड पीपीएच. So we used to train ourselves and our residents and our interns for a emergency. And exactly in the same way we are going to do PPH because management of PPH is like an algorithm, right? Which means first do this. If this is not effective, go do this. If that is not effective, go to the next step. So we are going to study PPH as an algorithm, and in the exams also it is going to be asked as an algorithm. In your real life also you will practice it like a algorithm, right? Now, so your call for help has come. What are the symptomatic things that the call for help is going to do? Let's say intern has come, my resident has come, and I am also there. So what are we going to do? So सबसे पहले we have to ensure 2 large bore IV cannula, right? कौन सा gauge? 14 and 16. So कम से कम ये यूज होने चाहिए 14 and 16 gauge IV cannulas. कलर याद है? Do you remember the color? चलो किसी एक का बता दो, 14 का बता दो. What is the color of the 14 gauge cannula? Anyone? 14 का कलर क्या होता है? जल्दी बताओ. You have to give me this answer, otherwise I'll not teach you आगे. This is something that you have to know. हाँ जी, 14 कौन सा कलर होता है? किसी ने आंसर नहीं किया. Orange. Okay, so 14 is orange in color. No, Ria, it is not black. Okay, 14 is orange in color. What about 16? 16 कौन सा कलर होता है? What about 16? Sixteen is gray, right? So it has to be large bore IV cannulas. ठीक है. साथ में क्या करेंगे? जब कैनुला डाल रहे होते हैं तो we also take what? Blood samples, है ना? So you should take blood samples minimum किस किस के लिए? CBC. So we would need hemoglobin and hematocrit, but preferably हम CBC लेंगे पूरा, right? But hemoglobin and hematocrit जरूरी है. Blood group एंड RH टाइपिंग का सैंपल जरूरी है और कोएगुलेशन प्रोफाइल का सैंपल जरूरी है, राइट? सो यू हैव पुट अ कैन्युला, यू हैव टेकन दी सैंपल्स. व्हाट डू? यू आर गोइंग टू स्टार्ट IV fluids, right? And which IV fluids do you start for resuscitation? Do you start crystalloids or do you start management of PPH? It is not done for prophylaxis of PPH. Yes? So I'm going to begin the uterine massage. Usually we will massage the fundus, but it can also be a bimanual massage. So दोनों तरीके से कर सकते हो. Either you can massage only the fundus or you can do a bimanual massage. साथ साथ जब IV fluids शुरू हुए हैं, what else should I start? Uterotonic. Okay, I have to start uterotonic. What else? I have to ensure that the placenta is complete. So, at the same time, I will ask someone to look for completeness of placenta. Let me see कौन मुझे बताएगा. When I say look for completeness of placenta, which side of the placenta would you see? Would you see the maternal side or would you see the fetal side? Right? Yes, so please tell me. Look for completeness of placenta. So we will look at the maternal side. What are you going to look for? Look for a missing cotyledon. कि कहीं कोई part of the placenta अंदर तो नहीं रह गया. So you look for a missing cotyledon. Right? And at the same time, I should also inspect the genital tract. So, we are doing quite a lot of things together. So, I am massaging the fundus. नीचे से I am also examining for any trauma to the genital tract. So, when I say inspect the genital tract, we want to look out for any trauma, right? I ask one of my interns कि मुझे placenta दिखा complete है कि नहीं है, and I have asked you to put uterotonic in the IV fluid. Now let us see what uterotonic are we going to do put. So which uterotonic are we going to put? So the drug of choice even for management of PPH is going to be oxytocin. Right, so the drug of choice is going to be oxytocin. We will start with 20 international units in 500 ml of normal saline or Ringer lactate, right? So it's given as an IV infusion. Please remember, do not give it in 5% dextrose. क्यों? क्या होता है? देखो PPH में you will have to give large doses of oxytocin and you will have to give it for a long time, right? Oxytocin, do you know, also has ADH like action? Yes, they're both coming from the posterior pituitary. So it also has ADH like action. So क्या होता है? If you give oxytocin in 5% dextrose and if you are giving large dose for long time in a electrolyte deficient media. So 5% dextrose is an electrolyte deficient solution. What will it cause? It will cause so as I said, it has ADH like action. It will cause water intoxication. Okay, so it will cause water intoxication. So don't give it in dextrose, give it in either normal saline or Ringer lactate. Oxytocin काम कर रहा है या नहीं कर रहा है बड़ी जल्दी पता लग जाता है by touching the fundus, right? So you are massaging, you are giving oxytocin. Now let's presume the fundus or the uterus is still atonic. So you have given her oxytocin and she is still atonic. What do? So now you can try other drugs. What all drugs can be given? We can give methergin, provided she is not having preeclampsia. So you can give methergin, 0.2 milligrams IM or IV. Yes. You can also give symptometrine. You can also give misoprostol, right? Now please remember, when it comes to misoprostol, the dose here which is given by WHO is 800 micrograms sublingual. क्योंकि आप PPH को treat कर रहे हो, we need a faster action, so it's not oral, it is sublingual. राइट मगर सबलिंगुअल के साइड इफेक्ट्स होंगे राइट सो इसीलिए अ लॉट ऑफ प्लेसेस डोंट गिव इट सबलिंगुअल एंड ऑल्टरनेटिव इज गिव इट per rectal. So if you have to give it per rectal, you can go up to 1000 micrograms, right? So you can go up to 1000 micrograms if you're giving it per rectally. The most important thing जो बच्चे गड़बड़ करके आते हैं एग्जाम में, can you give this misoprostol per vaginal? बिल्कुल नहीं. Please understand that the woman is bleeding. If you keep these tablets in the vagina, the blood will wash them away. So don't do these basic errors, okay? So when they say all the following routes can be used except, don't mark it as PV, don't mark it as IV. It's a tablet. You can't give it IV. उसको तोड़ के पानी में थोड़ी डालोगे. Yes? So don't do these basic errors. They want to see how much you really know and how much you've just mugged up. Okay? So misoprostol. And yet another drug is carboprost. Right? What is carboprost? It is PGF2 alpha. So it's a methyl analog of PGF2 alpha. Right? And the dose is 0.25 milligrams. It is given IM. Please remember, carboprost should never be given if the woman has asthma. Right? So never give carboprost if the patient has asthma. It causes severe bronchoconstriction. Apart from this, carboprost के बारे में आपको जानना है that you can actually give repeat doses as well, right? 15 to 30 minute के interval पे, so at intervals of 15 to 30 minutes, you can repeat the dose of carboprost up to a maximum of 8 doses, which comes out to be 2 milligrams, right? So you can give up to a dose of 8 doses at intervals of 15 to 30 minutes, often asked as an exam question as well. Another drug which has been recently approved, okay, so if somebody is not responding to oxytocin, you can give any of these drugs. You can give a combination as well, which means हो सकता है मैं methergin भी लगा दूं और misoprost per rectally भी डाल दूं. So you can give a combination also, right? Now, another drug which has been approved is injection Tranexa. So if your patient is not responding to oxytocin, you can give any of these drugs, as another agent. Now, injection Tranexa is 1 gram, okay, is what we give. But you have to give it slow IV. So, 10 ml of 100 milligram per ml solution, right? So 10 ml देना है हमें of a 100 milligram per ml solution, and this is given over a period of 15 to 20 minutes. So 1 gram is the dose, मगर उसको infusion की तरह देना है, ऐसे एकदम push नहीं कर देना है. It's not a bolus, right? So give it over 15 to 20 minutes. And injection Tranexa will be best effective if it is given within 3 hours of onset of PPH. Yes, so it is best used if it is given within the first 3 hours of PPH. Can we repeat the dose of Tranexa? Yes, you can. Okay, so we can also repeat the dose of Tranexa. Right? What category drug is Tranexa? It is an anti-fibrinolytic drug. Yes, so it's an anti-fibrinolytic drug. Now, ये इतनी सारी medicines या मैंने आपको drugs लिखवा दी, right? So I said, if she is not responding to oxytocin, you can give her other drugs as well. But what I want to know is, कितने टाइम तक ये ड्रग खेलते रहोगे? So up till what time will you just keep on giving one drug, then another drug, right? So there has to be limit, no? So please remember, ये जो आप drug therapy दे रहे हो, this is actually what we will give over first 30 minutes. Right? So जब से आपने management शुरू किया है, over first 30 minutes you will give her drug therapy. Now after 30 minutes, if the uterus is still atonic, yes, we have to do something more. खाली drug से बात नहीं बन रही. So if you have given it for 30 minutes and the uterus is not responding, you should try something more now, right? What are you going to try? You are going to try balloon tamponade, right? So we're going to try balloon tamponade. Now please listen to me very carefully again. Before I tell you what we do in balloon tamponade, I want to know from you, this is typically what I'm doing is the algorithm for atonic PPH, because that is what is most common, right? So in other words, I have ruled out genital tract trauma right at the beginning, and I have ruled out retained placenta right at the beginning, because unka management alag hai. If somebody is having trauma to the perineum, you have to repair the trauma. Yes, if there is retained placental tissue, you'll have to take out the placental tissue. So what I am teaching you is that you've ruled out retained placental tissue, you've ruled out trauma. So what you are dealing with is atonic PPH. Yes, but just to ask you here, if your patient has traumatic PPH, what would be the finding? So in case your patient has traumatic PPH, what is the finding? So please remember, in a traumatic PPH, the uterus tends to be well contracted. So if in the exams they ask you postpartum hemorrhage in the presence of a well contracted uterus, what do you think is the cause? The cause is genital tract trauma. Is this clear to everyone? Also, I taught you what is the finding in retained placental tissue. The finding in retained placental tissue is intermittent atonicity. Right? So intermittent atonicity, बीच बीच में uterus contract करेगा और बीच बीच में relax करके bleed करेगा. Right? So those are the findings which are suggestive of either retained tissue or genital tract trauma. ठीक है? Is this clear to everyone? Okay. So going back to atonic PPH. Balloon tamponade. Now balloon tamponade can be done with special devices. For example, a Bakri balloon tamponade. Okay, so for example, or I am sure you might have heard this, Sengstaken Blakemore tube. Where do you use these? So Bakri balloon tamponade or Sengstaken Blakemore tubes are something that we use for esophageal varices, right? And they can also be used for tamponade in PPH. But the problem is that these are not readily available, right, in the gynae departments or the labor wards. So what we do instead is make a balloon tamponade from the things that are available readily in the labor room, right? So what we would do is something like this. We would take a Foley's catheter. So let's presume this is a Foley's catheter, the adult Foley's catheter. And the balloon end of the adult catheter is put into the uterus, while the other end is connected via an infusion set to a bottle of normal saline or ringer lactate. Yes? And then you make it full flow. So what will happen is the balloon is going to expand inside, and when it expands, it is going to exert pressure on the open venous sinuses, and that's how it tries to stop the bleeding, right? So this is a balloon tamponade that we can make readily in the labor room itself. Acha, I didn't tell you. On the Foley's catheter, you have to put a condom, right? So on the balloon end of the Foley's catheter, we are going to put a condom. So we actually call it as a condom catheter. So it's actually the condom which is inflating inside the uterus, right? And we will generally put 500 ml of normal saline or ringer lactate. So this is one of the effective measures for postpartum hemorrhage, especially if it is atonic PPH. Please remember uterine packing. Right? Uterine packing का क्या मतलब है? That you will put gauze pieces into the cavity of the uterus to exert pressure and stop the bleeding. So uterine packing is not to be done because it leads to sepsis, right? So a lot of times the gauze pieces that you put inside are not sterile, and you land up with bigger problems like sepsis, okay? So uterine packing is not to be done. What you do is tamponade. Now, iske aage ka algorithm depends on the patient's condition. So, if your patient is still having PPH, what do you do further depends on the vitals of the patient. If your patient has stable vitals, the management is different. Whereas, if she has unstable vitals, the management is different, okay? Now, if the vitals are stable, what you can do next is uterine artery embolization. Right? Uterine artery embolization is a method or a technique which needs interventional radiology. So you need to catheterize the femoral vessels, you need to reach the iliac vessels, and then you need to reach the uterine vessels. And then you push gel foam particles into the uterine vessels to occlude it. So it reduces the blood supply and it reduces the hemorrhage as well. Okay. So uterine artery embolization can be done, but the problem is, as I said, most of the hospitals will not have this. They don't have a facility for radiological, interventional radiology, right? So if this is not available and vitals are stable, the next thing we can do is we are going to take the patient to OT and do what is called as B-Lynch sutures. Okay. So if UAE is available, you can do UAE. If it is not available and the vitals are stable, you shift the patient to the operating room and you will do a B-Lynch suture. Okay. Now what are B-Lynch sutures? These are uterine compression sutures. Right? So जैसा उनका नाम है, you put them on the uterus. When you tie these sutures, the uterus is going to compress. So, you're forcing it to contract. So, apne aap wo atonic tha, now you're forcing it to contract by putting sutures. Right? So, B-Lynch is the most common uterine compression sutures we use. But a couple of other names that you should know are Hayman's sutures and Cho square sutures. So they are all types of compression sutures, but what we use is B-Lynch, right? And typically if I explain you how we put the B-Lynch is like this. You have to give an incision onto the uterus. You will take your suture from the anterior aspect, right? Go to the posterior aspect of the uterus, still on the posterior aspect, and now come back on the anterior aspect. Now when you tie the A and the B ends together, the uterus will contract. ऐसे upside down भी और आगे पीछे भी, right? So it is going to contract. So those are what are B Lynch sutures. This is when your patient is hemodynamically stable. Now if the vitals are unstable, you are straight away going to shift the patient to OT, and you will do bilateral uterine artery ligation. Why are we not doing B-Lynch sutures? Because B-Lynch sutures take time. आपको वो लगाने में थोड़ा टाइम लगता है. उतनी देर में इतना सारा खून बह जाएगा, and she is already unstable. So first you want to reduce the bleeding. Do you understand this? First you want to reduce the bleeding by doing a uterine artery ligation. So remember, the uterine artery ligation is done bilaterally. दोनों तरफ करना है. It is done at the level of internal os. Okay, so it is done at the level of internal os. एक और यूट्रस की ब्रांच है जिसको भी हम लाइगेट कर सकते हैं आफ्टर डूइंग लाइगेशन एट द लेवल ऑफ इंटरनल ऑस. सो पहले यू विल लाइगेट इट बायलैटरली एट द लेवल ऑफ द इंटरनल ऑस, फिर ऊपर जाते हैं एंड यू विल लाइगेट व्हाट? डू यू नो दैट द यूटराइन आर्टरी मेक्स एन अनास्टोमोसिस विद ओवेरियन आर्टरी. So then you will also ligate the anastomosis with ovarian artery. This will reduce the blood loss. You will get some more time, and when you get time, then you can try B-Lynch. Yes? So पहले मैंने क्या किया? If the vitals are unstable, I'm पहले trying to reduce the bleeding. So once I reduce the bleeding by uterine artery ligation, now I can try B-Lynch. Lekin if you have done B-Lynch also, you've done uterine artery ligation also, the patient is still bleeding, she is hypotensive or has unstable vitals, what do you think is the last resort? So if none of this works, what is the last resort? The last resort is hysterectomy. Right? So in the end, if nothing seems to work, you will land up doing a hysterectomy for your patient. Please understand there is another artery that we can ligate. It's called as internal iliac, anterior division. मगर इसमें प्रॉब्लम क्या है? The anterior division of internal iliac ligate करने के लिए we need surgical expertise and we need more time because उसके लिए बहुत dissection करना पड़ता है. So if your patient is hemodynamically unstable and uterine artery ligation hasn't worked, B-Lynch hasn't worked, don't waste time by searching for the internal iliac and ligating it. You must proceed to hysterectomy. So generally, because ये सब करते करते patient definitely unstable होगी, don't try the internal iliac ligation, straight away go on to hysterectomy. Yes, is this clear to everyone? Yes. Okay, so I said, agar after the balloon tamponade my patient is hemodynamically unstable, I am straight away shifting to the operating room and I don't try B-Lynch first because B-Lynch takes time, she will keep bleeding. So what I do first is I reduce the bleeding by doing a uterine artery ligation. Once I have reduced the bleeding, then I try B-Lynch. Okay? Right? Is this clear? So the order is reverse. Right? Which means if the patient is hemodynamically stable, you do B-Lynch first, then you do uterine artery ligation. Whereas if the patient is hemodynamically unstable, You first do uterine artery ligation, then try B-Lynch. Is it clear? And when you have done both and it's not working, you go on to hysterectomy. Yes, is it clear? Disha, is your doubt cleared, beta? In fact, सबका doubt clear होना चाहिए. Anastomosis. Okay. So what I was saying is, if you look at the blood flow to the uterus, अगर ये uterus है, तो uterine artery ऐसे होती है, वो नीचे से आती है, meets the uterus at the level of internal os, then the uterine artery crosses the, travels up, keeps giving branches, और जब वो ऊपर आती है, it is going to anastomose with the ovarian artery. So this is what I said, that you will ligate here, that is the first point of ligation, so on both the sides, and once you have done this, you will also ligate this second point, क्योंकि नहीं तो blood flow यहाँ से आता रहेगा. ओवेरियन आर्टरी भी प्रेगनेंसी में बहुत डायलेट होती है, 3 times डायलेट होती है. So that is also giving a lot of blood to the uterus. So just ligating at the level of internal os will not help. Ligate also its anastomosis. So here it is anastomosing with ovarian. Is it clear now, Disha? Right? So I said ligate here, ligate here. Ligated at 2 points. Okay? Is it clear? पलक, मैं esophageal varices नहीं पढ़ा रही हूँ. मैं बोल रहा था कि Sengstaken tube and Bakri balloon tamponade are originally used for bleeding esophageal varices. That's what I said. Okay? Yes, Disha. If the patient is hemodynamically unstable, देखो, this is what I am saying. If the patient is unstable, you do ligation first, then go to B-Lynch. The ligation will be done at 2 points, internal os, anastomosis. Then I said if the patient is stable, it is the reverse. You do B-Lynch first, then do ligation. Yes, is it now clear? And when you have done both and she is still bleeding, go on to hysterectomy. Yes? Okay, perfect. So this is what you would do as a last resort. Please remember, if possible, okay, if possible, we should do a subtotal hysterectomy. So if possible, we should do a subtotal hysterectomy. Subtotal का नाम है supracervical hysterectomy, right? By which I mean you remove the uterus but spare the cervix. Why? Because she is a younger female in the reproductive age. You want to preserve the sexual function. So if possible, try and do a subtotal hysterectomy. But if patient is bleeding a lot, and especially from the lower segment, then you will have to go in for a total hysterectomy, which means you will remove the uterus along with the cervix. Is this clear to everyone? Okay. Now, this patient of yours, let's say you landed up doing a hysterectomy. She was already unstable. She's lost a lot of blood. She would be going to the ICU. You will be transfusing her with a lot of blood and blood products. Can you tell me what important complication can this patient develop? What important complication can this woman develop जिसका अभी आपने ऊपर hysterectomy किया है? So one of the important complications that she will develop is DIC. Yes, so disseminated intravascular coagulation, right? So always remember, if somebody is bleeding this much, they will or can land up with DIC, which is what is consumptive coagulopathy. Typically, this patient, despite having her uterus removed, will again start bleeding. So she'll have internal bleeding, She can start bleeding from the operative sites, right? And that's what tells you that she has gone into DIC. Is this clear to everyone? Okay. So this is how you manage atonic PPH. And it is really important that you know the algorithm, not only for your exams, but also to manage patients if you land up taking obs and gynae in your post-graduation. And I really wish that some of you take up OBGY and do great. This is something that is going to help you throughout your life, okay, to make a difference in other people's life. Okay, so now as far as traumatic PPH is concerned, we have already sort of talked a little about it when we talked about perineal tears. So here I'm not going to talk about perineal tear. In case your patient has had a cervical tear, you just have to repair the tear with continuous sutures. Right? So it could be perineal tear, it could be a cervical tear. What else can it be? It can also be a hematoma, which is very common in labor rooms, right? So you should know, in case you come across a hematoma, what are you going to do? So telling you a few things that you should know for hematomas. So please remember that these hematomas can be vulval hematomas, or they could be vaginal hematomas. मैनेजमेंट में कोई फर्क नहीं है, प्रेजेंटेशन में भी कोई फर्क नहीं है. The reason why I'm just telling you that it could be vulval or vaginal is because vulval are more easier to diagnose, they're more easily seen. Yes, vaginal would need more effort from your side. You have to separate the labia, you have to see the vagina, and then you will be able to pick up vaginal hematomas. So you have to know that there is an entity called as vaginal hematoma, there's an entity called as vulval hematoma. Also, when you talk about vulval hematomas, which vessel has tears? This is going to be the internal pudendal vessels. Right? So branches of the internal pudendal artery. Whereas if it is vaginal hematomas, the cause or source of bleeding is branches of uterine artery. Right? How would a hematoma present? So a hematoma can present as, or the most common presentation is going to be pain. So the woman is going to complain of local pain, right, which could be, she would say, either in the episiotomy site or she would say in the vagina. So the most common presentation is pain, but the other presentations can be inability to pass urine, which could be because of simply the size of the hematoma or because of the intense pain, right? So inability to pass urine could be because of the size which is obstructing, or it could be because of the intense pain the patient has, right? And yet another presentation is shock. So sometimes there is a lot of bleeding in the hematomas and they can present as shock. शॉक लेकिन ज्यादातर वल्वल और वेजाइनल हेमेटोमास में नहीं मिलता. शॉक इज मोर ऑफ अ फीचर ऑफ broad ligament hematoma. So, on either side of the uterus there is this potential space which is broad ligament. So lots and lots of blood can collect here. The problem with broad ligament hematoma is that external bleeding is very little. और इसीलिए ये पकड़ में नहीं आता. एक्सटर्नल ब्लीडिंग बहुत कम है, लेकिन इंटरनल ब्लीडिंग हो रहा है, एंड जब तक आप उसे पकड़ोगे, she would already be in shock. And that's actually why you get to know that there is internal bleeding, right? So broad ligament hematomas can present as shock as well. Diagnosis of a hematoma is very easy. How would you make a diagnosis? So a simple local examination would help. So what you would see is a bluish, tender swelling, right? So you will see a bluish tender swelling, and that's how you see that it is a hematoma. Majority of times when you talk about management of hematoma, it is conservative. What are we going to do? So, she has pain, so we will give her analgesics. And along with this, we will give her ice pack. Ice pack क्या करेगा? Vasoconstriction. So, जिस vessel के branches से bleeding हो रहा है, वो probably stop हो जाएगा. So, majority of times, we simply do a conservative management. We give analgesics, we give ice packs, and we monitor the patient. Where you will monitor her vitals, and you will monitor the size of the hematoma. Right? Now, because majority of times the management is conservative, आपके exam वाले लोग उल्टा पूछ लेते हैं. By which I mean, they will ask you कि कौन से hematoma में फिर operate करना है, right? So, what would be an indication for surgery in hematoma? So, surgery is done only if hematoma is expanding, right? So अगर hematoma बढ़ रहा है size में, then yes, she would need an operative intervention. मगर ये कैसे पता लगेगा कि hematoma बढ़ रहा है? So एक है by actually keeping track of the size. So if it is externally visible, you can keep a track on the size and see if it is expanding. But sometimes it is expanding internally, not on externally. By internally I mean the bleeding is happening within the tissues, right? So then जब आप बाहर से देखोगे आपको साइज बड़ा नहीं लगेगा, but it is expanding internally, and then you have to rely on the patient's symptoms. So if it is expanding internally, the patient will say she has excruciating pain. Excruciating का मतलब समझते हो? Something that is not bearable by the woman, right? So because it is internally dissecting in the muscle tissues, it will cause intense pain. So excruciating pain, a pain that the woman can't bear, is telling you that there is an internal expansion. And the third obviously way that you would know that it is a huge size or there is an internal expansion if she lands up into shock. So if a woman is coming to you with shock और बाहर से एक छोटा सा 3 सेंटीमीटर का हेमेटोमा है, don't say I will do conservative, it's only 3 centimeter. So no. So it means there is more that you can see. So probably what you are seeing is only a part of it and there is a lot of internal expansion, right? So these are the things that will tell you that there is expansion and that's when you should operate. Yes? So this is what you should know about hematomas. What other trauma can happen? So when we were talking about trauma, and if I go back, so there could be perineal tears, there could be cervical tears, it could be a hematoma. What else? It could be two more type of traumatic injuries. So one is uterine rupture, which is quite rare, and the last is a uterine inversion, right? So these are the kind of traumas or traumatic hemorrhage that you can come across and you should know how you're going to handle them, right? So I will first talk a little about rupture and then I will talk about uterine inversion. Yes? So, as I said, rupture uterus is not something that is common in the postpartum time. Most of the ruptures happen when, can you tell me? Intrapartum. वो भी किस में होते हैं? Previous cesarean. So most common cause of uterine rupture is previous cesarean. And I said the most common time is intrapartum. So postpartum is less common. But yes, it can happen. I want to ask you, can a non-scarred uterus rupture? So I want to ask you कि ठीक है स्कार है और इसलिए वो रप्चर हो गया, ये सबको समझ में आता है. बट क्या ऐसा हो सकता है that the uterus has no scar और फिर भी वो रप्चर कर जाए? Is it possible? Then yes, rare or less common, but yes, even non-scarred uterus can rupture. Let me see if you can tell me under what conditions can a non-scarred uterus rupture? एक तो मैंने पढ़ाया ही है, so you should actually be able to come up with that one. बताओ, what condition will a non-scarred uterus rupture? Very good. Yes, so Ayushi is right. Obstructed labor. In fact, we will ask you, when we ask you about most common cause of a rupture of a non-scarred uterus, you should answer it as obstructed labor. Okay, so then you should answer it as obstructed labor. The others are grand multipara. Okay, so in them there can be a spontaneous rupture and it could be drugs like oxytocin, like misoprostol. They can also cause rupture uterus and it could also be because of Mullerian anomalies, right? So it may rupture because it was an anomalous uterus, right? I have already talked about signs and symptoms of rupture and what you do if it is a rupture uterus, so I'm not going to repeat that. Remember, it is an emergency. You have to take the patient up for an emergency laparotomy. Okay, so management of rupture uterus is emergency laparotomy. Is this clear to everybody? Oh, okay. Then talking about inversion. This is something which is not common, so it's a rare thing to happen, and one of the reasons why it will happen is because you did a cord traction without counter traction. So you've given a cord traction but without giving a counter traction on the fundus. How is uterine inversion different from prolapse? So prolapse में क्या होता है? Uterus सीधा का सीधा ही बाहर आ जाता है. So it's actually the ligaments which are becoming weak. So वो ligaments भी नीचे आ जाती हैं, uterus भी नीचे आ जाता है. Inversion ऐसा नहीं है. Inversion में the ligaments are still attached where they are supposed to be attached. लेकिन uterus inside out fall करता है, right? So it is traveling through its own cavity and it falls out. Now, because the uterine attachments are the same, can you tell me what will happen to these ligaments if the uterus falls out? So if you can see, the ligaments will have a intense stretch, right? So the ligaments will have a intense stretch. Because of the intense stretch on the ligaments, as soon as the uterus falls out, the patient will go into neurogenic shock. And this will happen immediately after delivery, right? So basically क्या होता है, आपने बेबी का डिलीवरी लिया and you pulled out the placenta, और placenta के साथ, so यहाँ पे placenta भी बना देते हैं, ये placenta भी है. So placenta के साथ uterus बाहर आ गया, and as soon as this happens, the woman goes into neurogenic shock. Okay? Now, because this uterus has fallen out, it can't contract. Yes? So, eventually it begins to bleed. So, the first thing that happens is neurogenic shock. Then there's going to be bleeding. So, she will now have PPH. And eventually this woman will go into hemorrhagic shock. Right? So, what I'm trying to tell you is that it is again an emergency. Okay, so it is an obstetric emergency. You will have to handle it like an emergency. How will you make a diagnosis? So making a diagnosis isn't difficult. So you will see this round smooth mass which is lying outside, right? So you will see a mass lying outside. Which is also bleeding. And what else साथ में क्या होगा? When you do a PA exam, you will not feel the fundus, right? So a mass is lying outside, and on PA exam, fundus is not felt. So this is what tells you that there is a uterine inversion. Right? So diagnosis is definitely not difficult at all. It's very obvious. इतना बड़ा uterus बाहर निकल के गिर जाएगा. You can't really miss it out. What are you going to do is important. So whenever I say it's an obstetric emergency, I try and give things in an algorithm so that you know what to answer when they ask you what do you do next and what do you do next. So सबसे पहले क्या करेंगे? You are going to call for help. Right? Saath saath. When I write plus, it means it is done side by side. Please discontinue oxytocin. Now, if you are wondering, ma'am, why आप ही तो कह रहे हो कि bleeding हो रही होगी, तो why discontinue oxytocin? वो इसलिए बेटा क्योंकि यूट्रस बाहर गिरा है और उसका इलाज है कि उसको वापस डाला जाए. लेकिन वापस डालने के लिए I want the uterus to be relaxed. If it is contracted, I will not be able to push it inside. Right? So I have to ensure that the uterus is relaxed. So I discontinue oxytocin. I start the ABC. ABC is airway, breathing, circulation. So put IV lines, start fluids, right? Whatever जो हमने पढ़ा है वो करते हैं. Right? Send the baseline investigations, वो सब करोगे. And once you have done these things, what do you do next? So you have called for help, you have stopped oxytocin, you are doing the ABC, and now you will do manual repositioning. Right? Which means manually you will try and put the uterus back. ये कैसे करना है? You will push the fundus. So fundus बाहर होगा. You will push the fundus along the long axis of vagina. So push the fundus along the long axis of vagina. Please understand one very important thing. Placenta वहां अगर attached है, leave it attached. Don't try and remove the placenta. So leave placenta attached. Okay? So push the fundus along the long axis, leave the placenta attached. Kabhi kabhi when you are pushing it in, you may feel a constriction ring. So if you feel a constriction ring while you are putting it in, what do? You will have to apply a little pressure. So apply pressure to the part of the fundus so apply pressure to the part of fundus which is nearest to the ring. तो थोड़ा प्रेशर लगा के अंदर रिंग के उसको पुश करने की कोशिश करो. So apply pressure to the part of the fundus which is nearest to ring. अब दो ही चीजें हो सकती हैं, या तो आप सक्सेसफुल हो टू पुश इट बैक या आप अनसक्सेसफुल हो, राइट? सो व्हाट डू आई डू if I am successful in pushing the uterus? So if I am successful in putting it back, I will now start oxytocin. Then remove placenta. Okay? But if I am unsuccessful, so if manual removal fails, then what do? The reason is most likely the constriction ring. So what you do now is you give a uterine relaxant. Right? So now you give a uterine relaxant. It could be terbutaline. Right? It could be even nitroglycerine. NTG IV देते हैं, terbutaline subcutaneous देते हैं. So you give a uterine relaxant and then try, or I will write, reattempt manual repositioning. So अब आप क्या करोगे? You will give a relaxant and then you will reattempt manual repositioning. अभी भी क्या हो सकता है? You can get successful or you can get unsuccessful. If you are successful, do the same things. Start oxytocin. Okay? You start oxytocin and then remove placenta. But now if you are unsuccessful, most of the times the woman is going to be in shock, right? So she's been bleeding quite a lot. So now you proceed with laparotomy. Okay, so you proceed with laparotomy. In case the patient is stable, right? So if the patient is stable, laparotomy se pehle we can try hydrostatic repositioning. हाइड्रोस्टैटिक मतलब विद द प्रेशर ऑफ फ्लूइड. मगर प्रॉब्लम क्या है कि मोस्ट ऑफ अस आर नॉट एक्सपीरियंस्ड इन द हाइड्रोस्टैटिक मेथड, तो हम लोग ये प्रैक्टिस नहीं करते हैं. इट इज आउटडेटेड. बट एज पर द गाइडलाइंस, यस, इफ यू नो हाउ टू डू इट and if the patient is stable, you do or you can try the hydrostatic method of repositioning. It was first given by the surgeon called as O'Sullivan and it is named after him only. It's called as the O'Sullivan's method, right? So if you know how to do it and if the patient is stable, you can give it a try. But majority of times, as I said, the patient would be unstable or you would not know how to do hydrostatic method. So we proceed to laparotomy, okay? And in the laparotomy, the most common method we will try is Huntington's method. Okay, so what we will try is Huntington's method. Yes, so is trauma and traumatic PPH clear to everyone? Is the algorithm clear to everyone? I hope you will not do any mistake if they give you questions on obstetric emergencies. If you look at my notes, most of the time when I teach obstetric emergencies, they will be in an algorithmic way. ये करो फिर ये करो फिर ये करो, क्योंकि एग्जाम में भी क्वेश्चन ऐसे ही आता है. So I really want to know from all of you, are you clear with this? Yes? Yes, is the algorithm clear to everyone? Okay. The third reason we said for bleeding or PPH is retained placental tissue. So again, we don't need to do a lot about it. But when we talk about retained placental tissue, okay, what do you think is the treatment? You have to remove it, as simple as that. Okay, so if it is placenta subcenturiata, manually remove the small lobe. So you put your hand inside और जो retained smaller lobe है उसको निकाल देते हैं, right? What you can easily do is you can do a bedside ultrasound, right? So if you feel or you want to know whether something is left in the uterus or not, you can do a bedside ultrasound. It will show you the smaller lobe and then you can manually remove the lobe. But if there are placental membranes which are retained, ये दिखते नहीं है, right? या तो ये बहुत छोटे छोटे tissues होते हैं which are retained, so these are actually adhered to the uterus. You can't remove them manually. So if it is placental membrane tissues, you would have to do a curettage, right? So to remove those retained products, you will have to do a curettage because these are going to stick to the uterus. You can't remove them manually. Is this clear to everybody? Yes? So you will have to take her to OT. You will have to do a curettage and remove those sticky placental membranes in the uterus. आपको पता है ये कब होता है? This is very common in preterm delivery. You know, लोगों को लगता है प्रीटर्म डिलीवरी बड़ी आसान होगी क्योंकि बेबी छोटा सा होता है एंड इट कम्स आउट इजीली, बट प्रॉब्लम उसके बाद शुरू होती है. सो इन प्रीटर्म डिलीवरी द प्लासेंटल मेम्ब्रेन्स ऑफ्टन आर गोइंग टू बी स्टिकिंग इनसाइड एंड शी विल हैव अ ब्लीडिंग, राइट? सो देन यस, you may have to go ahead and do a curettage as well. Is this clear? Okay. Coming to the last cause of bleeding, and that is thrombosis. One of the things that you should know where your patient will have defective coagulation and therefore she will bleed is a woman in DIC, right? So a woman who is in DIC will also have postpartum hemorrhage. तो मेरी बात ध्यान से सुनो. PPH can cause DIC and DIC will also manifest as PPH. Do you understand this? So if there is massive hemorrhage, there is consumption of the coagulated factors, she goes into DIC. DIC could be because of other reasons as well, right? And then she can start bleeding and she can present as PPH. Do you understand this part? Because if you understand this part, then I will move further. Yes? Now, ये कौन सी condition है where the woman is in DIC? So, abruption I have taught you. I have taught you what would you do if it is atonic, because this will actually cause atonic PPH. One of the important things where you have to know that the woman can be in DIC and it has a very characteristic presentation is amniotic fluid embolism, right? Amniotic fluid embolism is also called as anaphylactoid syndrome of pregnancy, right? So this is not actually anaphylaxis, it is anaphylaxis-like. So anaphylactoid, right? And as it says, it's an embolism. So what happens is amniotic fluid particles are going to enter into the pulmonary circulation and they present as an embolus. But the thing here is that there is a very rapid deterioration of the patient. So there is a very rapid deterioration of the patient, that much more than what you see in a pulmonary embolism. The reason is anaphylaxis, right? So not only it's a embolism, the body is also responding to it like an anaphylaxis, and therefore there is a very rapid deterioration of the patient. And why am I telling you this? Because you have to know that this condition has a high mortality rate. Modern obstetrics में mortality rate better हो गया है, but it is still pretty high, right? So कम से कम 20% है. So it has a high mortality rate. And let us see how or what is a typical presentation of the patient. So this patient who has who has amniotic fluid embolism will present with sudden onset of breathlessness. Okay, so there is a sudden onset of breathlessness, but very rapidly this woman develops hypotension and she goes into a cardiac arrest. She can even go into coma, right? So breathlessness, hypotension, cardiac arrest or failure, right? And she can go into coma. And while she's going into coma, because of this hypotension, there is hypoxia. You could also see seizures. So because hypotensive है, there is cerebral hypoxia, और हो सकता है इस time पे patient को seizures भी आ जाए. So this rapid sequence that you see is the characteristic presentation of amniotic fluid embolism. So breathlessness, hypotension, a cardiac failure, coma and seizures, right? This is what is called as phase 1 of amniotic fluid embolism. And most women actually don't survive this phase. But what happens is if they do, they will enter into phase 2, which is characterized by DIC, and now she will also start having bleeding for vaginum, right? So after those symptoms, she will start having bleeding and postpartum hemorrhage. So phase 2 is actually characterized by DIC and hemorrhage, right? Now, मैंने ऐसा आपको बोला है that amniotic fluid embolism can happen in the postpartum time, but more commonly AFE happens during labor. So not after delivery, but during labor. So intrapartum, especially when the membranes rupture, because that's when the amniotic fluid is more likely to enter the maternal circulation, right? So most of the times it will happen during labor, but yes, it can happen also postpartum. Right? Caesarean section is a risk factor for amniotic fluid embolism, right? मगर ये काफी rare चीज है, so it's not something that you come across very commonly. Now what I want you to know is amniotic fluid embolism is a clinical diagnosis, right? It has a very characteristic presentation. So if you see this, you say it is AFE. We do not have any laboratory test. Okay. So there is actually no lab test that can confirm or refute the diagnosis. Right. So it is a clinical diagnosis, but because it is rare, we say it is a diagnosis of exclusion, which means if you are finding no reason for her PPH, right, if there is no other identifiable cause or reason for her PPH, then think of amniotic fluid embolism. Don't think the most common cause of PPH is amniotic fluid embolism. No, it is kept as a diagnosis of exclusion because it's very rare, right? And it's a clinical diagnosis. Sometimes you say that you can take samples from the pulmonary vessels. So yes, that is we have done those things. So you can take sample from the pulmonary vessels, and this blood sample can show you what? It can show you vernix, it can show you lanugo hair of the baby, it can show you amniotic cells. Magar problem kya hai? That this is not diagnostic. Why? Because we have seen if you take blood samples from the pulmonary vessels of women who have not had amniotic fluid embolism, even they will show you these things. So a woman who is hale and hearty and sitting, if you take a sample after delivery, you may see sample of pulmonary vessel containing vernix, lanugo and amniotic cells. So presence of these things is not diagnostic of amniotic fluid embolism. Absence does not rule out amniotic fluid embolism. Is this part clear? So you can't say कि अच्छा ये सब नहीं था इसलिए AFE नहीं है. No, AFE is a clinical diagnosis. Is this clear? Yes? Have I made myself clear to everybody? Okay. So now, once you have done all these causes of PPH, I also want you to know these very basic things. In general, the most common cause of shock after delivery is postpartum hemorrhage. So the most common cause of shock after delivery is postpartum hemorrhage until proved otherwise. Okay? If we say shock immediately after delivery, then think of inversion. क्योंकि PPH में shock immediate नहीं होगा. The woman has to lose some amount of blood volume, at least 25% to go into hypotension, right? So, in fact, 25% to actually show a fall in blood pressure, 50% to go into hypotension. So, PPH में immediate shock नहीं होता है, right? So, immediate shock should make you think towards inversion. And if we say unexplained shock after delivery, then think of amniotic fluid embolism, because here the keyword is unexplained, which means there is no obvious reason of why the woman has gone into shock. Then think of amniotic fluid embolism. Yes, is this clear? So these are some of the important immediate postpartum complications that you should know, or different types of hemorrhage that you should know can happen in a woman who is immediate postpartum. There are a few more postpartum complications that I want you to know, but we can take a little break if you want. Yes? So today we will finish on time, so we should be able to finish by 10 o'clock today, right? No संस्कृति, no D dimer. मेरे बच्चे, जब मैंने फिजियोलॉजी पढ़ाई थी संस्कृति, रिवाइज करेगी आज जाके, मैंने तेको बताया था D dimer is physiologically raised in pregnancy. You cannot use it as a test of DIC. Okay? और D dimer भी DIC बताता है, ये नहीं बताता कि उसका कारण क्या है. Right? Okay. So we will take a short break, and I think 10 minutes is good. So I will restart the class at 8:42 or 45. ठीक है? So 8:45 पे class restart करते हैं, and we will do some more postpartum complications in our patient that you should know, and then we are done with obstetrics. Okay? Yes, Disha. Today obstetrics will be over, so we will celebrate. Tell me, how do you want to celebrate? So today we will finish obstetrics, and tomorrow you would start gynecology. So today we will celebrate. सोच के रखो celebrate कैसे करना है, ठीक है? चलो, let's take a quick break and let's come back. I will start the class at around 8:45. Okay? Right? Are you back? Is everybody back? Okay. So let's move towards the आखिरी पड़ाव of obstetrics. Are you all ready? So we are still talking about some of the important postpartum issues that we should know, right? Okay, now अभी हमने क्या देखा that one of the most important things that we come across in postpartum phase is, especially in the immediate postpartum phase, is postpartum hemorrhage, है ना? Do you know a certain condition which can happen because of massive PPH? Can it lead to some complication? Yeah, apart from DIC and things that I've done, can it also lead to something else? So it can also lead to something which is called as Sheehan's syndrome, right? Now, massive PPH, how does it lead to Sheehan's syndrome? Now, you know, pituitary gland jo hai, in pregnancy, it enlarges quite a lot, right? So, it in fact increases by 130%. So that's how much it enlarges, right? So pituitary is going to enlarge massively in pregnancy. And because it enlarges massively, it needs a lot of vascular supply, right? So it needs more vascular supply. And what happens is that when there is postpartum hemorrhage, which is this massive, it can cause what? It can cause a reduction in this blood flow, and it can cause infarction of the pituitary gland. And this is what is called as Sheehan's syndrome, right? So this is what is called as Sheehan's syndrome. What is the presentation of this woman who would have Sheehan's? So despite the fact that you know that she has just now delivered a baby, she will not be able to lactate. So failure of lactation is the most common presentation of Sheehan's syndrome. So she will not be able to breastfeed the child, right? The second most common presentation is persistent amenorrhea, right? So अब मेरी बात ध्यान से सुनोगे, वो ये है कि if a woman does not breastfeed, so normally if a woman does not breastfeed, her menstrual cycle should return, right? So if she does not breastfeed, the menstrual cycle should return by 6 to 8 weeks. Okay? मगर यहाँ पे क्या होता है, despite the fact that she is not lactating the child, the menstrual cycles do not return and she remains amenorrheic, right? So that's what I said, the most common presentation is failure to lactate and the second most common presentation is persistent amenorrhea. What can be the other features of Sheehan? So, you know, you just have to remember as far as other features of Sheehan is concerned, that in Sheehan syndrome, it is actually the anterior pituitary which is affected. Okay, usually the posterior pituitary is spared. Okay, so usually posterior pituitary is spared. So all the hormones that come from the anterior pituitary, so whether it is LH, FSH, or it is prolactin, or it is thyroid, or it is ACTH, right? She can have even growth hormone. So she can have presentation of all these, deficiency of all these hormones. So yes, you should know that sometimes Sheehan syndrome can also present as adrenal failure. You should also know that it will present with a reversal of secondary sexual character. So there is going to be a regression of secondary sexual characters, right? So all these hormones can be affected with with Sheehan syndrome. Yes, is this clear? Then there is another entity that you should know, and that is called as peripartum, okay, cardiomyopathy. So peripartum cardiomyopathy क्या होता है? This is again not a common thing to come across, but yes, you should know what it is. So this is development of systolic heart failure, right? So development of systolic heart failure, which means ejection fraction less than 45% in the absence of another identifiable cause of heart failure, which means she is a woman who is in her peripartum phase. Now, what do you understand by peripartum phase? It means around the time of delivery. So actually this heart failure happens anywhere between 36 weeks to 5 months postpartum. So it can happen any time from 36 weeks to 5 months postpartum, and that is why it is called as peripartum cardiomyopathy. And how does this woman present? This woman presents with simply heart failure. और जब आप इसको evaluate करोगे, you will not find any underlying cause of her heart failure, right? So it is called as peripartum cardiomyopathy. Who are the women who are at risk of developing peripartum cardiomyopathy? So these are women with advanced age, so advanced maternal age. Then it is multi-fetal pregnancy. So women who have multi-fetal pregnancy, and especially women who had pre-eclampsia or eclampsia, right? So these are the women who are at more risk of developing peripartum cardiomyopathy. Now, why this cardiomyopathy is happening? We do not still know the exact cause. So a lot of etiologies have been proposed, and they say that it could be multifactorial. So the cause of heart failure could be multifactorial, which means it could be because of angiogenic imbalance. So the proposed mechanisms are: number one, angiogenic imbalance. It could have a genetic role. It could be because of hormones of pregnancy. Okay. There could also be a contribution by the inflammatory mediators. And very important, something that I want you to know is that it could be autoimmune. And lastly, there is also some role of prolactin, which means we have seen that in these women who develop peripartum cardiomyopathy, they have altered prolactin. Okay, they have altered prolactin processing. So prolactin has been said to have a direct role in this peripartum cardiomyopathy. Now, as far as diagnosis is concerned, diagnosis will be made by echo. So you'll have to get a 2D echo done, which will show you that the ejection fraction is less than 45, and that's how you make a diagnosis. You should also remember that in the echocardiography, a lot of times you will see that left ventricle is dilated. So majority of times, right? So majority of times the left ventricle is dilated, but please remember this is not required to make a diagnosis. Which means even if left ventricle is not dilated, you can still make a diagnosis of peripartum cardiomyopathy, provided the EF is less than 45 and there is no other cause of heart failure. Yes, is this clear to everyone? Okay. Management is just like management of any other heart failure. So you have to do the management of, or the standard management of, heart failure. The only thing which I feel they could ask in the management part is there any other special thing that you can give? Then yes, there is some role of bromocriptine, although currently it is investigational, right? क्योंकि हमने बोला that altered prolactin processing, and this prolactin has some role in peripartum cardiomyopathy. These clinical trials are saying that bromocriptine may be useful in these women. Currently, we are not using it as a standard practice. As I said, currently it is investigational, but it may prove to be useful. Right? So 2.5 milligrams 2 times per week is what you will give in peripartum cardiomyopathy. But please understand, whenever we are going to give bromocriptine to these women, we should also add anticoagulation, because it is seen that adding bromocriptine to these women increases the risk of thromboembolic complications, right? So along with bromocriptine, you should add anticoagulation, because there is increased risk of thromboembolic complications. Yes, is this clear to everyone? So, please remember, although I did say that it could be autoimmune, currently, okay, there is no role of immunosuppressive therapy. क्योंकि जो मैंने बोला कि what is the etiology, वो अभी सिर्फ proposed है, we don't have a definite mechanism. So इसीलिए currently there is no role of immunosuppressive therapy in peripartum cardiomyopathy, right? Is this clear to everyone? Okay. Now please understand, these were the two things that are linked to prolactin and postpartum phase that you should know. Adding a few, statements here that you should know. If somebody asks you prolactin levels maximum कब होते हैं? Do you see maximum prolactin levels during pregnancy, or do you see maximum prolactin levels in the postpartum phase? Anybody who can answer that? When do you see maximum prolactin levels? So please remember, they are seen in the 3rd trimester, not in the postpartum phase. In fact, what you have to know is prolactin levels fall after delivery by 50%, right? So the prolactin levels fall after delivery by 50%. They're still above normal and sufficient to maintain lactation, but actually it shows a fall after delivery. So maximum levels are not seen in the lactation phase, they are seen in the 3rd trimester. Yes, this is because even the placenta and the decidua are secreting prolactin. So it's not just the pituitary, the decidua and the placenta also secrete prolactin, and maximum levels are seen in the 3rd trimester. One more thing that I want you to know when it comes to the postpartum phase is sometimes our normal postpartum patients would develop fever, right? So they will develop fever in the postpartum phase. So I'm not going to go into details of every cause of fever. For example, it can be a urine infection and so on and so forth. I'm going to talk about the 2 most important things that you should know. So one is an entity called as postpartum endometritis. So as you can see from the name, it is an infection of the endometrium. So yes, and this is going to present as fever. But along with fever, what are going to be the things that you will see in the patient which tells you that it is endometritis? Because those are the key words that you should grasp in the question and to say that it is postpartum endometritis. So apart from fever, the patient will have uterine tenderness. Okay, she will have tachycardia, obviously, because she has fever as well. So uterine tenderness, tachycardia, subinvolution of uterus. So you all know that after delivery, the uterus has to go back to the non-pregnant size. लेकिन यहाँ पे वो slowly जाएगा and it remains enlarged, right? So uterine tenderness, tachycardia, subinvolution of the uterus. Also, this uterus feels soft. It's not characteristically the postpartum uterus. So it feels more soft, and that is why it is also going to bleed. So she may have presentation of bleeding per vaginum as well, right? So a subinvoluted soft uterus which may even bleed. Apart from that, some women may have malodorous lochia. So lochia is the normal postpartum discharge, but it's not malodorous. So here it's going to be a malodorous lochia. And sometimes if the fever is high, there may be chills as well, right? So this is the classic presentation of postpartum endometritis. They're all keywords. You have to pick them up. The other hint that they will give you in the question is that patient will be a case of cesarean section. So ये बात याद रखना, क्या postpartum endometritis का most important risk factor is cesarean section. Yes? Acha, anything that I taught you early in the pregnancy part, which is a risk factor for endometritis, and I'm sure मैंने वहां पे भी highlight किया होगा. Chorioamnionitis. So other risk factors are so especially if the membranes are ruptured for a long time, chorioamnionitis. So these are also important risk factors for postpartum endometritis. Now please remember that this is a polymicrobial infection. So you know, I'm not going to give you the most common organism here. So most of the times it is a polymicrobial infection, and therefore we are going to start them on broad spectrum antibiotics. Classically, we would give AMPI, Genta and clindamycin, right? So classically we would put them on AMPI, Genta and clindamycin. Now, if your patient has a favorable response, right? If your patient has a favorable response, which means the temperature will come down, yes, within 24 to 48 hours of starting of the antibiotics, right? Then you have to simply continue the drug therapy, and we will usually give it at least for a span of 7 days, right? So then you continue the drug treatment and that's it. But if your patient does not respond, okay, to these antibiotics in the first 48 hours, which means the fever is persisting despite antibiotics. So fever goes beyond 48 hours despite these antibiotics. Then you have to think of something else, right? So think of other causes. And one of the important thing that you should think of now is called as septic pelvic thrombophlebitis. Okay, so this is the second important reason for fever and difficult to make a diagnosis. But what we say is, you suspect endometritis, you start them on antibiotics, and if they don't respond within 48 hours, you think of septic pelvic thrombophlebitis. By itself, it is a rare condition. It's not a very common thing to happen. And as the name suggests, here there is pelvic vein thrombophlebitis, right? The reason for this thrombophlebitis is number one, endothelial injury of the pelvic veins. Okay. Second reason is venous stasis. And third reason is something that you all know, that pregnancy and especially postpartum is a hypercoagulable state. So hypercoagulability, venous stasis and endothelial injury is the reason why this is happening. Again, this is not just thrombophlebitis, it is septic as well. So infection का भी element है. So there is infection and there is thrombophlebitis, दोनों चीजें हैं, right? And again, when I say it is septic, it will be again polymicrobial, right? So it will also be polymicrobial. Now, what are the veins that are involved? So it could be two veins. It could be either the ovarian veins or it could be the deep pelvic veins. Okay, so it could be deep pelvic veins. The reason I want you to differentiate the two is that they will have a slightly different presentation. For example, when the cause is ovarian vein, the woman is going to be more ill. So she's going to look more ill, right? She will have fever, she will have abdominal pain, right? So she looks more ill, she has fever, she has abdominal pain. Generally, it is right ovarian vein more commonly involved than the left vein. The reason is a longer course of the right vein and lack of valves. ठीक है, so right vein में valves उतने नहीं होते हैं and it has a longer course. So right vein is more commonly involved as compared to the left vein. On the other hand, if it is a deep pelvic vein, these women have isolated fever. खाली fever होता है इनको. There is no abdominal pain or tenderness. काफी बार, if it is the ovarian vein which is involved, right? When you do a PV exam, you will feel, or you can feel, not always you will feel, but you can feel the cord-like vein. So ovarian vein में कभी-कभी we are able to palpate this cord-like ovarian vein on a PV exam and then the diagnosis is confirmed, right? अगर आपको doubt है, cord-like vein feel नहीं हो रहा है, doubt है, then what you can do is you can order a CT or a MRI scan. But again, not always the CT and MRI scan will be showing you any specific findings, right? So बहुत बार जरूरी नहीं है कि आपको thrombosed vein दिखेगी, but yes, sometimes you may see the thrombosed vein. On the other hand, if it is pelvic veins, there is no PV finding. You will not see anything or feel anything on a PV exam, and there will usually be no CT and MRI findings as well. So it's only going to be a clinical suspicion. Yes. So इसलिए मैंने बोला कि making a diagnosis is very difficult, especially if it is the deep pelvic veins which are involved. Okay. हम आपको कहाँ confuse करेंगे यहाँ पे? पूछेंगे अगर एंडोमेट्राइटिस है पेशेंट को या सेप्टिक पेल्विक थ्रोम्बोफ्लेबाइटिस है, इज देयर एनी रोल ऑफ ब्लड कल्चर? सो नो. प्लीज रिमेंबर, चाहे वो एंडोमेट्राइटिस हो, ओके, या वो पेल्विक थ्रोम्बोफ्लेबाइटिस हो, ब्लड कल्चर में कुछ नहीं आएगा बिकॉज दीज आर लोकलाइज्ड इन्फेक्शंस. इट्स नॉट अ सेप्टिसीमिया, right? So generally blood culture is not useful for diagnosis. Okay, so generally blood culture is not useful for diagnosis. अब treat कैसे करना है? देखो दो entities हैं तो दोनों entities को treat करना है. So if it is septic, you will have to continue the antibiotics. But there is also thrombophlebitis. So you will now add anticoagulation. Right? So you will add anticoagulation. Please remember the anticoagulation जो आप दे रहे हो कब तक दें? So if a cord-like vein was felt in the examination, or there is CT scan or MRI evidence of thrombosed vein, अगर इन दोनों में से कुछ भी है, then anticoagulation is given for 6 weeks. So if there is a definite evidence, right, so if there is a definite evidence that it is septic pelvic thrombophlebitis in the form of a cord-like vein or in the form of a CT MRI finding, then you will give anticoagulation for a span of 6 weeks. But if there is no definite evidence and it is a clinical suspicion, then you will give anticoagulation for 48 hours after fever subsides. So जब fever बंद हो जाएगा उसके 48 hours तक you will give the anticoagulation. Is this clear for everyone? Yes. So these are two very, very important infections and they are not the routine things to make a diagnosis. For example, UTI, you all know how to make a diagnosis, right? But these two are something very specific, and therefore I wanted to highlight especially endometritis and septic pelvic thrombophlebitis. Another very common cause of fever in the postpartum period is what, Patao? It is mastitis, right? So a very common cause of fever in the postpartum period is mastitis. Classical presentation is pain, fever, there will be redness, right? Malaise, right? So all these are going to present, and usually this happens in the first 6 weeks, right? So pain, fever, redness, malaise, myalgia, those are the presentations. The reason क्या होता है? Reason is prolonged engorgement of the breast. Antibiotics, again the same thing, Sangameshwar. A minimum requirement is 48 hours after the fever subsides for IV antibiotics, right? So the minimum requirement is 48 hours after the fever subsides. दोनों treatment उतना देना है because this is a clinical suspicion. It's not a proven diagnosis. Okay? That is IV. उसके बाद we will shift them to oral antibiotics. Okay? Now, so prolonged engorgement and poor drainage is what is the reason for mastitis. Acha, is it always infective? So no, that's what I'm trying to tell you, that most of the times it is not infective. Most of the times the reason is engorgement and poor drainage. So अगर कोई आपसे treatment पूछेगा, please don't say start them on antibiotics. No. So initially it has to be only symptomatic treatment, right? The symptomatic treatment is in the form of non-steroidal anti-inflammatory drugs. You ask the woman to keep cold compresses, and she has to ensure a complete emptying of the breast. Right? So cold compresses, NSAIDs, complete emptying. अगर ये symptomatic treatment करने के बाद भी if symptoms persist, right? Beyond 24 hours. So, you know, you have done this treatment for 24 hours, complete emptying, steroidal drugs and cold compresses. If the symptoms persist beyond 48 hours, that's when you think of infective mastitis. And that is when you will start antibiotics. Okay? Let me ask you a very basic question. Is mastitis a contraindication for breastfeeding? No, it is not a contraindication for breastfeeding at all. In fact, you have to tell her that she has to encourage breastfeeding. Problem kya hota hai? When the baby suckles, the woman is going to have even more pain. So it's a vicious cycle. Usko pain hota hai, so she doesn't breastfeed. And because she is not breastfeeding, it keeps getting engorged. So the treatment itself is complete emptying. If she cannot allow the baby to suckle because the breast is too tense, then manual extraction of milk or breast pumps should be used, right? So complete emptying, painkillers and compresses के बाद अगर नहीं response आता, that's when you start her on antibiotics. Needless to say, what organism do you think is it going to be? Staph aureus. Yes. So if it is infective, it is going to be the boss Staph aureus. Okay. And very commonly, it could be MRSA as well, right? So very commonly, it could be MRSA as well. So those are, most of the times, we do not have any absolute contraindications to breastfeeding. ठीक है? So बहुत rarely हम किसी भी चीज को contraindication for breastfeeding बोलते हैं. So, majority of times, you know, even if she's on ATT, right, she can breastfeed. So most of the times, especially infections, these are no indications for or contraindications for breastfeed. Okay. So whether you talk about, you know, any kind of infection, most infections are not going to be contraindications. Okay. Now, the only other part that I want to do now is an overlap part. Overlap part matlab एक newborn baby, and that's how is the transition from obstetrics to pediatrics. I so wish कि मेरे बाद आपकी pediatrics की class होती, so it would have been so much more in flow then. But yes, what I want to cover in very short now is something that you should know about perinatal infections. Now, why do I say that it is actually an overlap topic? Because most of the times, what presentation they give you in exams is a newborn baby with certain findings, right? So they will say, baby hai, usko ye hai, ye hai, ye hai. Batao which infection in the antenatal period could be responsible for this. So most of these perinatal infections are actually to be done in pediatrics, but yes, I will help you giving some key things that are, if they are written in the question, or if you see written in the presentation of the baby, you can have a fair idea about what perinatal infection is it, right? And also this is an overlap with microbiology. So they could ask it in a format where they're asking you core microbiology about that organism. Yes. So before I go give you some specific features about these perinatal infections, what I want you to know is basics. The basic is this, that you know, if a woman is getting infection during the antepartum period, what would be the effect on the baby? So please remember this, transmission of the infection increases as POG increases. So the tendency that the baby will be infected or will get the infection by transmission will be higher as the POG increases. So it will be higher in the third trimester as compared to the first trimester. But the severity of infection decreases as POG increases. ठीक है, सो ट्रांसमिशन इंक्रीज होता है मगर सिविरिटी डिक्रीज होती है. इसका मतलब अगर कोई भी कंजेनाइटल सिंड्रोम्स हैं, राइट, जिनमें बच्चे मैलफॉर्म्ड होते हैं, सो इफ यू टॉक अबाउट कंजेनाइटल सिंड्रोम्स, whether it is rubella syndrome, varicella syndrome or any syndrome, congenital syndrome in the baby कब होगा? When the mother is infected in the early part of the pregnancy or in the later part of the pregnancy? Can you tell me this? If a baby shows a congenital syndrome, let's say rubella syndrome or a varicella syndrome, what is the likelihood? Did the mother get the infection in the early first and second trimester or she got it in the third trimester? So it will be early pregnancy. Yes. Okay. Now, when you talk about these perinatal infections, certain things are common findings. तो कॉमन फाइंडिंग्स के बेसिस पे आप डायग्नोसिस नहीं बना पाओगे. डोंट वेस्ट योर टाइम ऑन इट. बाय विच आई मीन, with all the infections the baby can show these things. What are these common findings? The common findings are hepatosplenomegaly. So भाई अगर बच्चे में लिखा है hepatosplenomegaly है तो मैं नहीं बता सकती वो रुबेला था या वो साइटोमेगलोवायरस था या वो टॉक्सोप्लाज्मोसिस था, राइट? आई कांट. सिमिलरली थ्रोम्बोसाइटोपिनिया, similarly rash is a very common thing with viral infections. So unless we use some typical words, it's not easy to make a diagnosis just on the basis of rash. Growth restriction and seizures, right? So these are certain common findings which you can see with almost all types of perinatal infections. So don't worry about this. इन words को ignore करना है, इसीलिए बता रही हूं. I have to teach you what words should you keep in your mind if you want to make a quick answer on what is the likely infection. For example, let's look at this. If the infection is toxoplasma, what would be written in the baby, right? So in the baby, the classic findings of the triad are chorioretinitis, hydrocephalus, and intracranial calcifications. But please be very careful. These intracranial calcifications are diffuse calcifications, right? So the classic triad of toxo is chorioretinitis, hydrocephalus, intracranial calcifications which are diffuse, right? Can you tell me what else will be written in the MCQ to give you a hint that it is toxo? Cat, exposure to cat of the pregnant woman, or eating of undercooked meat. Right? So exposure to cat or undercooked meat. So if you see these words, you should go and mark the answer as toxoplasmosis. Right? What about rubella? Let me see if you all can give me the answer for rubella. What is the classic triad of rubella? Sensory neural hearing loss, cataract. The moment you see a newborn baby and they are saying cataract, please go and mark rubella. Okay? So cataract लिखा है newborn baby में, rubella mark करके आना और कुछ मत mark करना. Right? So SNHL, cataract and cardiac malformations. Which is the most common in rubella? Do you know? PDA. Right? So the most common is PDA. It could also be pulmonary stenosis, but the most common is PDA, right? Any other keyword that they will say if it is rubella? Blueberry muffin rash. So I said if they write some characteristic thing about the rash, then it's different. But if they simply write rash, then it's very difficult to say what it is. So if they use the word blueberry muffin rash, then it is rubella. Congenital rubella syndrome कब होता है? Congenital rubella syndrome is if the mother gets infection in the first 16 weeks. So उसके बाद अगर मदर को इन्फेक्शन होता है तो congenital rubella syndrome नहीं होगा. And these are actually features of congenital rubella syndrome. Right? So SNHL, cataract, cardiac malformations. Right? So, but अगर कोई आपसे पूछे रूबेला ट्रांसमिशन मैक्सिमम कब है? In the first 16 weeks or after 36 weeks? What would be the answer? So tell me, रूबेला का मैक्सिमम ट्रांसमिशन कब होगा? First 16 weeks or after 36 weeks? The answer is after 36 weeks. So please remember, transmission increases as POG increases, but severity will decrease. So after 36 weeks, the baby will not show the rubella syndrome. It will be a milder infection. Okay? CMV. What are the findings if it is CMV? Microcephaly. So remember, toxo में hydrocephalus था, CMV में more characteristic is microcephaly. देखो होने को दोनों चीजें हो सकती हैं, but you have to know what is more characteristic for CMV and what is more characteristic for toxo. Okay? So microcephaly, sensory neural hearing loss and periventricular calcifications. Right? So now this is not diffuse calcifications. This is periventricular calcification. Right? Also, please remember, CMV is the most common cause of congenital SNHL. It's not rubella. Okay? So the most common cause of congenital sensory neural hearing loss is CMV. Okay? Varicella. So anybody knows the classic findings with varicella? Anyone? The most characteristic thing is cutaneous scars. It's not a rash. The word is scar. So cutaneous scars and hypoplastic limbs. So if they show you a newborn baby who has hypoplastic limbs, cutaneous scars, and cortical atrophy. So cortical atrophy would दिखा नहीं सकते, but yes, this is the first two are very characteristic. So hypoplastic limbs and cutaneous scars are characteristic to varicella. अब दोबारा से same question पूछूंगी. Congenital varicella syndrome कब होगा? So if we talk about congenital varicella syndrome, the highest risk is if the mother gets infected between 13 to 20 weeks, right? So this is when there is a highest risk of congenital varicella syndrome. Has been a name's MCQ as well. Magar, there is another term where we will confuse you. Neonatal varicella. वो क्या होता है? Neonatal varicella तब होगा, tell me, when the mother gets infected close to delivery or in the first trimester. So when the mother gets infected in the first and the second trimester, there is congenital varicella. Neonatal varicella तब होता है when the mother gets infected close to delivery. Okay? So, two days before to 5 days after. I hope I am recalling this correct. I'll update you on this, but yes, I hope I am right on that. Maybe I'm forgetting it because this is more of a pediatric thing, but I'll let you know. Okay. So abhi confirm kar denge, but neonatal varicella is different from congenital varicella. Okay. Please remember this. Is this clear? Oh, it's the reverse, I think. It should be 5 days before to 2 days after delivery. Isko correct kar lo, please. So that is what I was getting confused with. I think I'm correct now. So it should be, yes, 5 days before to 2 days after delivery, and that's when it is going to be neonatal varicella syndrome. So please remember, congenital varicella is very different from neonatal varicella. Okay, is this clear? Okay. Quickly, what about Zika virus? Zika virus abhi INI-CET ka question hai, magar it was a core microbiology question and not to do anything to do with actually obs and gynae, so micro or pediatrics. But anyways, what is the findings again here? Microcephaly. So this was one of the hints in the INI-CET questions. No, Disha, very different. Neonatal varicella will have different presentations as compared to congenital varicella. Okay? उसमें ज़्यादा functional problem होती है बच्चे को rather than malformations. ठीक? So Zika में there is microcephaly. This was the hint in the INI-CET question as well. Apart from that, there is hypertonia. Very important. It's quite unique. So hypertonia and hyperreflexia. Right? So hypertonia, hyperreflexia, right, is what you see with Zika along with microcephaly. Zika maybe there can be intracranial calcifications. And there can also be SNHL. So there can be intracranial calcifications, there can be SNHL, there can be ventriculomegaly, right? But more characteristic is what I have told pehle, microcephaly, hypertonia and hyperreflexia. Okay, so that is going to be for Zika. HSV. So again, HSV के लिए बहुत ज़्यादा नहीं जानने की ज़रूरत है. HSV can be perinatal, acquired close to delivery, or it could be congenital as well, right? So HSV in the baby can come during the course of delivery, or it could be congenital. The most important thing that I want to tell you here is, which I also mentioned in cesarean section when I was teaching you, that if a lady has, vesicles on her genitalia and she is close to term, is it an indication for doing a cesarean section? Yes. So please remember, active HSV in a woman at term, okay, is an indication for cesarean section. We will not allow a vaginal delivery in this case, right? The presentation in the baby which is typical is conjunctivitis, initial presentation, and mucocutaneous vesicles. Okay? So, conjunctivitis and mucocutaneous vesicles. The presentation is different if it is congenitally acquired, which means early in pregnancy. So if HSV is early, it will rather cause, skin vesicles and ulceration. So instead of mucocutaneous vesicles, there will be vesicles on the skin which will break into ulcers. There will be microphthalmia. And this could also be a cause of microcephaly, right? So this could also be a cause of microcephaly. Yes, is this clear to everyone? Okay. As far as HIV in pregnancy is concerned, what I have done is I have actually given you the most latest guidelines from NACO in your concept book itself. So जो आपकी concept book में guidelines हैं वो most recent NACO guidelines हैं, हमारी national guidelines हैं. Please follow that unless there is an update on it, right? So far after I have made the book last year there is no update, so it is all updated. So I'm just going to here give you the highlights that you should know. Please remember these basic things. I told you that testing for HIV in pregnancy is what kind of testing? Testing is opt-out. Yes, it is an opt-out testing. The second thing I want you to remember is that all HIV positive women will receive ART therapy. Okay, so they will receive antiretroviral therapy from the first antenatal visit itself. And this will be irrespective of CD4 count. Right? So irrespective of our CD4 count, all HIV positive women will receive ART from the first antenatal visit itself. Okay, if somebody has opened the concept book, maybe you can tell the others the page number, so they will, you don't actually have to write this down. I have written everything in the guidelines itself. In the class, I'm trying to tell you which all things are very important and you should know them. You should have a fair idea about what to answer, and I'm trying to highlight them for you. So anybody? Okay, 197. Yash और दर्शित सबसे पहले पेज नंबर बता देते हैं. So if you see, you know, we have tried to keep the concept book very, very, very concise and very, very, very effective. At least I am very proud of the concept book that I have come out with. मुझे ऐसा लगता है कि अगर आप end में, if you revise the concept book, right, it is going to be a wonderful resource. It has everything in points. It has all latest things. So इसको रखो और notes को रखो, and you know, it is just the perfect combination that you need, right? So everything that you see, I have given the essential PPT-CT package as well as the algorithm for evaluating the woman, right? So you can just go through that. But yes, this is what I want you to know. Remember, when we talk about ART, it is a triple drug therapy. Okay, and it is a fixed dose regime, right? So it is fixed dose and it is triple drug therapy. So what are the drugs? Lamivudine, efavirenz and tenofovir, right? So she has to receive the triple drug therapy. Please remember, these drugs have to be given lifelong. Okay, so it has to be lifelong therapy for her. The most important obstetric part that you have to know, and Indian guidelines are different from international guidelines. So the most important obstetric part is HIV positive in India is not an indication for cesarean section. Okay, so it is not an indication for cesarean section. In India, we are doing vaginal delivery and we say cesarean is reserved for obstetric indications, right? So cesarean section will be reserved for obstetric indications. If we ask you on what factor transmission depends, right, then more important than cesarean section or vaginal delivery, the most important factor for transmission is high viral load. And that is why the government is stressing that cesarean करना important नहीं है, antiretroviral देना important है. Because if you are giving antiretroviral and you reduce the viral load, vaginal delivery can reduce the transmission. yes, or will not increase the transmission. So high viral load is the most important factor for transmission of the virus. Is it clear to everyone? Yes. Now please remember certain things that you should not do if the woman is HIV positive in labor. So sabse pehle, can you give oxytocin? Yes. In fact, augmentation of labor should be done because you want to get over with it quickly. So augmentation of labor should be done, and this augmentation should be done by using oxytocin, not by doing ARM. So आप ARM नहीं करोगे, you will allow for spontaneous rupture. Okay? Sanskriti, because when you're going to do instrumental delivery, there are going to be more perineal lacerations. Yes, and the transmission is going to increase, right? So wherever the chances of bleeding is increasing, the chance of transmission will also increase. Okay? So you should do an augmentation of labor, but don't do an ARM. You should avoid internal fetal monitoring. Okay? For example, using scalp electrodes, right? These things should not be done. As I mentioned before, avoid instrumental delivery. Reduce the number of cesarean PV examinations. Right? So these are certain things that you should try and do so that you are reducing the transmission. But the most important way to reduce the transmission is antiretroviral therapy. I have already told you that it is delayed cord clamping. Right? It has to be delayed cord clamping. Right? What about the baby? Should you give the baby any drug? Yes or no? So all babies of HIV positive women will receive nevirapine. Okay? So all babies of HIV positive women, not all, it will be one baby. So babies of HIV positive women will receive nevirapine prophylaxis for a span of 6 weeks. Right? So they will all receive nevirapine prophylaxis for a span of 6 weeks. Yes, so those are the key things from obstetric point of view that you should know about HIV in pregnancy. There is other part of pediatric testing ki kab test karna hai. I'm sure the pediatric people will take it up. I have tried to give it in short here as well. There should not be a discrepancy between what I have written and what the pediatrics people will teach you, because these are standard NACO guidelines. So these are not my guidelines. These are NACO guidelines. Right? So on this note, we finish today's class and we finish obstetrics as well. Right? So if you have any doubts, you let me know. Tomorrow you will start with gynecology. My sole aim in the class has been to give you concepts, right? To make you understand the approach rather than to mug up. So I really don't want you all to mug up. Please ensure that you are reading the concept books along with your notes. You should do the worksheets at the end of the concept books. Very important. It will ensure कि वो आपके दिमाग में चीज बैठ जाए. So active recall is very important. Please continue doing what? DQB questions. Very, very important. DQB has all sorts of questions. There are loads of clinical vignettes, right? There are image-based questions. There are chapter-wise questions. So please do them. If you have any doubt, feel free to ask. Madhurima, I will just answer your query, but I hope you're all members of the Facebook Club 2021. अगर कोई बच्चा ऐड नहीं हुआ है, please write to me either on Instagram or on Telegram or on the Facebook Messenger. inbox me and I will get you added to the club 2021, right? Where we, do a lot of interaction throughout the year. It is a continuous 24/7 doubt solving, right? So do that. If you have not yet in the club, let me know. Tomorrow class is 5 p.m. मान हमेशा क्लास 5 p.m. ही होती है. I am a little naughty. I start the class at 4 p.m. So I'm very sorry for that. But thank you so much for bearing with me. I always need a little more time. So मैं थोड़ा जल्दी शुरू कर देती हूँ. But otherwise, Ultimate App Live class starts at 5 p.m. on weekdays. Okay. And okay, so the last doubt which Madhurima had was, why are we doing delayed clamping? क्योंकि मधुरिमा द मोस्ट इंपॉर्टेंट थिंग वॉज टू रिड्यूस द वायरल लोड. तो बेटा जब तूने वजाइनल डिलीवरी भी अलाउ कर दी, एंटी रेट्रोवायरल भी दे रही है, तो अब 1 मिनट डिले करके कोई पहाड़ टूटेगा? टेल मी, आर यू गोइंग टू इंक्रीज द ट्रांसमिशन बाय डिलेइंग द कॉर्ड क्लैंपिंग बाय 1 मिनट आफ्टर अलाउइंग अ कंप्लीट वजाइनल डिलीवरी? व्हाट डू यू थिंक मधुरिमा? Okay, so Anjali, just drop a message to me, beta. I will get you added to the club. Okay, right? So it was. So please understand, this 1 minute delay does not affect the transmission. जो transmission होना था वो vaginal delivery में हो चुका होगा, right? So now your goal shouldn't be to save that 1 minute. So our goal as clinicians has to be to reduce the viral load, right? Okay, it was absolutely fun teaching, and I'm sure that a lot of new students who have joined today in the app live. So, कौन आज नया joinee है? So welcome, and I assure you that app live is going to be a great experience for all of you. As you can see, you have access to live classes, and you already have a complete DVL also. वो DVL आपके बैकअप के लिए. मान लो आप गायनी के साथ कुछ और भी पढ़ना चाहते हो अपने आप. Let's say you also want to study a little bit of pathology. So those lectures are also there, right? मगर आपके लाइव में सारी classes आएंगी on a rotation. So all lectures will come live, okay, in rotation in your course. But just to help you, a complete video library is also available. अगर आप अपने आप से कुछ अलग से देखना चाहते हो, so the video library is available. Okay. Facebook exclusive, DAMS exclusive club 2021. Okay. So DAMS exclusive club 2021 is the name of the club. Sanskriti within the course itself, बच्चे, when you exit this window Sanskriti, तो आप ऊपर देखोगे कॉलम है वीडियोस, फिर है नोट्स एंड टेस्ट, फिर है कोर्सेज और फिर है डिस्क्रिप्शन. सो जब आप वीडियोस पे प्रेस करोगे संस्कृति, सारे वीडियोस आपको वहां दिख जाएंगे बेटा, राइट? सो यू विल सी अ कंप्लीट DVL, राइट, एज वेल एज योर लाइव क्लासेस. जैसे जैसे आपकी लाइव क्लास होगी, द DVL that is already there will be replaced by your live class. So eventually आपको आपके लाइव क्लास का ही वीडियो मिलेगा once they happen. Okay, is this clear to everyone? DQB. Okay, so you have to exit completely. और जब आप exit करोगे, in the app, in the bottom column of the feed section, there is called as a study section. ठीक है, bottom में study section होता है. If you press the study section, you will get the Q bank, you will get the tests, and you will also get the talking CRS. ठीक है, समझ में आ रहा है? CRS का भी कॉन्सेप्ट बुक भी आपको ऑनलाइन भी मिलेगी, राइट? टू द इनिशियल जॉइनीज वी आर गिविंग कॉन्सेप्ट बुक एज हार्ड कॉपीज, लेकिन बाद में उसके हार्ड कॉपी नहीं मिलेंगे, राइट? सो बाद में यू विल गेट only in the app. Yes, so yes, we will try and send out the planners as well. We will try our best to send you the planner. So Anushka, exit करके देखना. In the bottom panel there is study. When you press study, you will launch DQB, you will launch your tests. आपके सारे टेस्ट भी वहीं पे आएंगे, including your grand test and your subject wise tests. So I hope you all know that app live में सारे inclusion दिए गए हैं. Okay, so you will get SWTs with videos. You will also get your GTs with video discussions. Okay, they're also a part of your app live course, right? Beta, CRS is the older name, Sangameshwar. Now for you all, it is concept book. We have replaced the CRS. There is no CRS now from this session. So from this session, it will only and only be the concept books. And these concept books are, you are going to get the e-version of the concept book in the app. Okay, Sangameshwar? Is that fine? Okay, so on this note, thank you very much for bearing with me. It was an absolute pleasure to teach you all. Right? Take care. Good night. And if you have any doubts, please feel free to ask them anytime. If you're not added to the club, just send me a message. I will get you added. Okay? Chalo. Good night, everybody. Take care.